Thank you all, everyone, for showing up this morning. Really appreciate it. My name is Dr. Brandon Manley. I'm here at Moffitt. I'm one of the urologic oncologists. Been at Moffitt for about 8 years. Most of my practice is kidney cancer, so I have a real passion for this, and we're lucky enough to have two great groups here, the Kidney Cancer Association along with the Judy Nicholson Kidney Cancer Foundation. So for any of you here who don't know a lot about them, you're going to hear a little more here in a second, but we really appreciate them, and they're great resources for patients, investigators, doctors, all of us, so we really appreciate that. And obviously, a lot of the sponsors that are here today, we couldn't do it without them, so we really appreciate their help. I do want to mention real quick that this whole thing was not done by myself. There was a great team of people that helped put this together. So real quick, I want to thank Karen Irby, Epi Bass, and Paolo Rodriguez for all of their help. Really appreciate it. All right, so as all of you probably can tell, this isn't the biggest thing in the world. This is meant for patients. This is meant for answering questions. There's no stupid questions. That's something they say to my third graders class all the time. You know, so feel free to ask, right? We don't expect anyone here to be world famous kidney cancer experts, right? This is all about education, and every patient's journey, your journey may be different, so don't feel bad about asking a question that maybe only applies to a subset of patients, but this is sort of a good avenue to do that, so we encourage that as well. You'll notice some QR codes on all the papers in front of you. Obviously, we'd really appreciate it if you can give us some feedback. You know, we do many of these events with the KCA, and Judy Nicholson does many of these events around the country, and we're always looking for ways to improve, so if you have any feedback, we'd really appreciate that as well. All right, we'll go ahead and move on a little bit here. I'm going to introduce a couple people to you that are very important, not just to kidney cancer, but to many of the people around the country going through this journey. Start with Gretchen Vaughn from the Kidney Cancer Association. She'll come up here and give a few words about her organization. Thank you.
Good morning. Good morning. Thank you, Dr. Manley. We're so excited. I just realized for the first time that I have never been to Tampa and not ever been to Moffitt either. So I'm so thrilled to be here. We thank you all for taking the time to join us here today. I'm Gretchen Vaughn, the CEO and President of the Kidney Cancer Association. We are all so grateful to see a dedicated community here today, both from patients to caregivers, to support caregivers, which is my favorite one here today, to clinicians and our industry partners, all working toward our shared goal of improving and extending the lives of kidney cancer patients everywhere. For those of you who are unfamiliar with the Kidney Cancer Association, we solely exist to lead change through research, education, support, and collaboration. And basically to end this disease, but this is a perfect example of all of us coming here today as to what we do and why we do it. I'm no stranger to the cancer journey myself. I feel like there's very few people on this earth at this point who leave this world unscathed or untouched by cancer in some way. When my family went through the journey ourselves, I learned firsthand that even after 21 years of experience in this field, it still wasn't enough. It wasn't enough to navigate all the waters. It wasn't enough to know all of the terms. It wasn't enough to know all the right answers and make all the right decisions that were changing people's lives in that very moment. I still needed and will forever be grateful for all those that provided knowledge and guidance, or just a sympathetic ear, quite honestly. It's not an easy time, but that's kind of why we exist. That's kind of why the Judy Nicholson Foundation exists, and that's why we work really, really hard with each other and with the doctors and with industry to make this an easier journey for each and every one of you. We hope each of you leaves today feeling more informed and connected and empowered to take the next step in your journey, knowing that we are with you every step of the way. I want to thank Moffitt for being a key partner in driving research and quality care for kidney cancer patients everywhere. I have a full circle moment because even though I hadn't been to Moffitt before today, the president of Moffitt now is Dr. Patrick who is a wonderful human being, and I hope you get to meet him today. But so we'll get to see him. We used to work together at MD Anderson Cancer Center, and so we feel like I know that he is so passionate about making things happen, finding a cure, and doing better for each and every one of us. So we're thrilled to be here, and we're thrilled to have our sponsors that make this possible, Eastside and Exelixis and Merck. Together with Moffitt, our affiliate Judy Nicholson, and our industry partners, we hope you leave today feeling supported, inspired, and informed. And with that, I'll turn it over to Linda.
Hello, everybody. I'm Linda Anderson, the CEO of the Judy Nicholson Kindney Cancer Foundation. I'm going to keep this real brief. This is my first speaking here in public. For those who might not know us, I'm just going to invite you to come out to the tables, meet KCA, Judy Nicholson, see what we have to offer. We have all of our information out there. I want to thank Dr. Manley, Moffitt, the whole staff here. They are wonderful. Have been great with us, have been great partners working with us. Really appreciate all that they do and all the information that they have given us to share with you. We are Judy Nicholson. We are more of the once you're first diagnosed kind of where we start out. We're going to help you through your journey, get you where you need to go, get you information and things that you need to have and see. So please feel free to stop by, ask us any questions, any information you might want or need. We have great programs that are available and they're free, they're online. We have open forums, and you can just talk to other patients and caregivers. Jilla, who's in the back room with Judy Nicholson, handles our caregivers. Wonderful group that I invite everybody, whether you're a patient or a caregiver, please come join the groups. It's terrific. I do want to thank Eastside, Merck, and Exelixis for their support. Without them, we could not be doing this. So the pharma companies, they're still a very big deal to us. We greatly appreciate them. And with that, I want to thank everybody, Gretchen, Kendall, everybody from KCA. I love working with you. And let's get this day started.
All right, thank you, Gretchen. Thank you, Linda. So we'll go ahead and get started. Our first speaker today is Dr. Hayes. I just want to mention a little bit about Dr. Hayes. Part of obviously our goals here, not just through the KCA, Judy Nicholson, and us as providers and caregivers, is to do more, right? To push the limits, and that requires getting young, smart people involved in kidney cancer. I'm getting older. I won't be around here forever, and there needs to be a next generation. And really excited people like Dr. Hayes are showing an interest in kidney cancer, and I think will really push the field forward. So, without further ado, Dr. Hayes will be presenting just some basics on kidney cancer to get us started. Thank you.
Good morning. Good morning. I'm Mitch Hayes. I'm a urologic oncologist researcher, as Dr. Manley mentioned. Thanks so much again to everyone here today. I know there was a lot of people involved in making this happen. Thanks to you for coming out. Today I'm going to talk to you about Kidney Cancer 101 and also just about kidneys. I have no financial disclosure. This is an overview of what we're going to talk about over the next 15 minutes. It's going to be kind of a whirlwind, but my plan is to talk a little bit about some kidney cancer diagnosis and that process, and then talk a little bit about surgical treatments at the end. So every year the American Cancer Society will release cancer statistics about U.S. cancer cases. And so this is a very sort of commonly cited diagram that you will see in the literature. And if you haven't spotted already, you can see that kidney cancer makes up about 5% of cancers diagnosed in men and about 3% in women, which is about 80,000 cases per year in the U.S. The bottom half actually shows you sort of the deadliest cancers in the U.S. And luckily, kidney cancer is not on the top 10 list. It didn't actually always used to be that way. It's we've made a lot of strides over the last 20 years with therapies, especially for metastatic or stage 4 disease, and luckily, kidney cancer doesn't make the top 10. Okay, so how is kidney cancer discovered? Well, most kidney cancer is actually discovered incidentally, meaning your your doctor or healthcare provider was getting a scan for something completely unrelated, abdominal pain or back pain, and then it was found. And so, you know, it's because, you know, most patients don't have any symptoms. But, you know, I just want to kind of do a quick sidebar about, you know, where are your kidneys? What are they doing? So kidneys are actually, you know, most people have two kidneys, one on either side. And most of the time they're located in front of the 11th or 12th ribs in the back. They're about 10 to 12 centimeters in length. And if that conversion is not immediately apparent, if you just spread your fingers out like a USF bull sign, your kidney is slightly larger than that, okay? And the main job of the kidneys is to filter blood. So your kidneys will take the blood and it will remove all the metabolites and all the extra fluid and things that your body doesn't need. The kidney does other things too, which include things like maintaining your blood pressure or creating hormones to create red blood cells. But those jobs are actually shared by other organs. So the unique function of kidneys is to filter blood. And that sort of is going to be important with treatment decision making, because depending on somebody's overall kidney function, which is a reflection of how well they're filtering the blood, that's going to sort of weigh into the decision making about treatment. This secondary picture is actually sort of an internal anatomy of the kidney, and that's important when we're talking about specifically surgical treatments. So I just wanted to kind of briefly mention, you know, the internal anatomy. It's such that, you know, blood will enter the kidney in the center part. Urine will be made on the outer part and then be collected in the center part again. So the center part of the kidney, there's a lot going on. And so, you know, tumors can arise anywhere in the kidney, and when they show up in the center part of the kidney, that can kind of affect surgical treatment. Once urine is made, it will travel all the way down into the bladder. All right, so that's a little bit about kidneys, and let's talk about actually patient presentation in terms of kidney cancer. So unfortunately, there's not really any dedicated screening test for kidney cancer yet. And as I mentioned before, you know, a lot of this has to do with, you know, most kidney cancers are found incidentally because patients don't have any symptoms. But that's not always the case. You know, some patients will present with blood in the urine, or flank pain, sort of pain around the side of those ribs, or if it's large enough, there can actually be a palpable mass, meaning, you know, you can feel the mass on your side or from the front. They also call kidney cancer the internist cancer, because sometimes people can present with sort of more vague and nonspecific symptoms, such as weight loss, fever, or abnormal blood work. And then rarely when tumors have metastasized to other parts of the body, you can actually get symptoms from those tumors in other parts of the body as well. So those can be things like bone pain or neurological symptoms or cough. But, you know, once kidney cancer is suspected, you know, the first step is always dedicated imaging of the kidney and surrounding organs to see sort of where the kidney cancer has gone to, if it is kidney cancer. And I actually just want to sort of focus on that point for 1 second. You know, we've been talking this whole time about kidney cancer, but most people, when they're first diagnosed, are just diagnosed with a kidney mass. We don't really know what it is when you're first diagnosed. We have a good idea, but we can't say for sure, because cancer is a diagnosis that is made by looking at something under a microscope. So if there's no biopsy or surgical sample, then we can't say for sure that it is cancer. However, we can have a really good idea about what are the chances that something is cancer based on imaging. And actually, Dr. Thomas is going to talk about that next. So I'll leave that to her expertise. You know, there's other things that kidney masses can be. So that can be like a benign growth, or an infection, or other sort of non-growth type of lesions. It can also be like a cyst, which is sort of a fluid-filled sac, which can be cancerous or non-cancerous. And so needless to say, it can get a little complicated. Sometimes when, you know, the diagnosis is in doubt or the differential is a little bit longer, biopsy can be helpful. But that's not always the case either, because it may not affect actually proceeding with some definitive treatment. So biopsy may not always be necessary, especially in early stages. So at this point, you know, a lot of people, once they're diagnosed, they ask, how did I get this? And is it possible to pass it on to my children, for example? And for that, we look at the risk factors for kidney cancer. These are some of the most common ones. Kidney cancer is definitely one of those things that can run in families. And so it's never a bad idea to ask your doctor if there might be extra testing that might be needed to see if the kidney cancer is sort of part of a heritable condition that can be passed on to another person. Other people will also see sort of high blood pressure, obesity, and smoking and ask, if I had my blood pressure under control and I lost some weight and quit smoking, would that decrease my risk of kidney cancer? And the answer is probably yes. But also there's a lot of other good reasons to do those things. So it's always good to sort of consider new strategies to try and achieve those goals, which is obviously way easier said than done. Finally, there are some occupational exposures that can be associated with kidney cancer, usually heavy metals or sort of industrial toxins, but there are other professions that can be at risk too, like firefighters. Okay, so we've covered a lot so far. Now we can start to kind of get into the nitty-gritty about the types of kidney cancer and the staging, which tells us about the risk stratification of kidney cancer. Kidney cancer staging is very important. It tells us a lot about sort of what treatments should be pursued, which I'll talk about in a little bit, and also a little bit about prognosis. And so, whenever we've got that imaging, which is all, a lot of the information that we need for staging, our first question is, has the kidney cancer spread outside of the kidney into distant organs? We usually call that a distant or stage 4 type of cancer. And if not, what is, if it's confined to the kidney, what is sort of the size of the tumor, the primary tumor in the kidney? And also, which structures immediately adjacent to the kidney or right next to the kidney does the tumor involve? The stage 1 and 2 are primarily determined by size and the absence of invasion to surrounding structures. Whereas stage 3 usually involves some surrounding structures, and stage 4, you can still have a tumor that's confined to the kidney, but sometimes when it grows outside of the fat or into an adjacent organ, that is considered to be stage 4. And so really, a lot of that, it sort of goes back to this original picture of the internal anatomy of the kidney, where, if some of these structures are involved, then it may be, a stage 3 or higher type. There are, the other important aspect of risk stratification is talking about kidney cancer types. There's a lot of different ways to sort of classify kidney cancers nowadays. There's actually a recent release of a very long classification system by the WHO in 2022. But one thing has not changed, which is that the most diagnoses of kidney cancer are still what we consider to be renal cell carcinoma, or RCC. And most RCC is what we call a subtype called clear cell RCC. Clear cell RCC is named because of the appearance of what it looks like under the microscope. This is a representative image of a clear cell RCC. The cells there are sort of clear in appearance compared to other types of cells. There are other subtypes of RCC, such as papillary and chromophobe, and then there's also other very rare types that are determined sort of by the sort of underlying molecular biology of kidney cancer. So, like I said, this classification scheme can get really complicated, but it's actually a reflection of our very, very good understanding now of the molecular biology of kidney cancer, which has really been sort of a long process starting in the 90s that has gotten very refined in the current era. Okay, so once we've talked about risk stratification, staging, the type, the imaging, and all these factors, we can start to talk about sort of what is the treatment paradigm. And I like to talk about it in terms of a paradigm because it's not really a rigid framework at all, and most situations are going to have a lot of nuances that are not going to perfectly fit into this paradigm. But this at least gives us a way of thinking about kidney cancer treatment from sort of a 50,000-foot level. So in the first bullet point, we talk about kidney cancer that is confined to the kidney. In that situation, some treatment options can be active surveillance ablation or even radiation for early stage, like stage 1. But really, surgery is kind of the sort of gold standard of care that we compare everything to. So that's why it's underlined here, and we can do that for all sorts of stages that are confined to the kidney. Sometimes after surgery, folks will also now be receiving some sort of adjuvant systemic therapy, which is usually an immunotherapy. In the second point, we talk about kidney cancer that has spread to other organs. And in that situation, usually we get a biopsy first to confirm what the kidney cancer type is. And then somebody will go on to receive some type of systemic therapy, which is usually the backbone of treatment. And that usually includes targeted treatments or immunotherapies, but pretty much never chemotherapy. There are some rare types of kidney cancer that can respond to chemotherapy, but most systemic therapy for kidney cancer is immunotherapy and chemotherapy. And we do have some medical oncologists speaking today about some systemic therapies. Okay, so that, again, 50,000 foot level, that's sort of the treatment paradigm, okay? All right, so now, in the brief time that I have left, I want to talk a little bit about surgical treatments. There's a lot of people speaking today, but because I'm a surgeon, I just kind of want to talk briefly about what does surgery entail and when do we do it and what's the gist of it. There are two main surgeries that we do for kidney cancer, partial nephrectomy and radical nephrectomy. Partial nephrectomy is where we remove just the tumor and a rim of normal tissue, and we leave most of the kidney in place. Radical nephrectomy is where we remove the entire kidney itself. A lot of the times we can actually do either one of these surgeries minimally invasively. So, that can be robotically or laparoscopically, but that's with smaller incisions, and I can talk a little bit about the benefits of that. And then there's other sort of rarer situations where we might do some sort of complex surgery, which may involve a radical nephrectomy. Or removal of kidney cancer that has spread to some distant organs, but I'll come back to both of those in a second. So first, what is a partial nephrectomy? Like I said, you remove the tumor and a rim of normal tissue, and then you have to reconstruct the kidney, put the kidney back together again. This is actually, more complicated of a surgery to do than just removing the entire kidney because of that reconstruction part. Why would you do that? Well, the pro is that you get to save more kidney. The more kidney tissue you can save, that's going to be better for your kidney function. And so, again, it kind of goes back to, what is that baseline kidney function? For those who sort of go in with a lower than normal kidney function, saving kidney tissue might be a very big priority. The cons of doing it, as I mentioned before, it's more complicated. So the complication risk is actually a little bit higher. There's a lot of tumor and patient-specific factors that play into whether or not your surgeon might recommend one versus the other, but also patient preference. So this is, me and Dr. Manley talk about this in our office all the time. As I mentioned before, robotic and minimally invasive surgery is definitely an option for a lot of different people. Both myself and Dr. Manley do this. The advantages really are that the incisions are smaller, the recovery is faster, there can be less blood loss, and the pain is lower. But in terms of those long-term cancer outcomes, sort of like survival and recurrence and all these things that are related to longer-term things, those outcomes are fairly similar between the two, and also complication risks. So, sometimes minimally invasive surgery is just not feasible. So if it's not feasible and the surgeon is recommending open surgery, that doesn't necessarily mean it's the wrong thing to do just because there's these, advantages to minimally invasive surgery. You want to do what is the safest, way to do what needs to be done. As I mentioned before, there are some situations that sort of increase the complexity of surgery, and specifically, when there's larger tumors or tumors involving surrounding structures. And the only thing I'll say about this is that really sort of high volume medical centers are usually the best place to, one, get an opinion about this, and two, potentially get the procedure done, as we know complications to be lower at these places compared to places that don't do it as much. We're talking about situations in which the tumor might be involving the vena cava, which is a large vein in the middle of the body, or other surrounding organs. And then finally, there are some situations in which surgery can be done in kidney cancer that is spread to other organs that are beyond the kidney, such as the pancreas or lungs or the adrenal gland. But this is really more the exception than the rule, because we only do it for situations where there's limited disease, and the goal of therapy in this situation usually is to pause systemic therapy for an unknown amount of time. So it's not typically done, with curative intent, so to speak. But I'll just leave it at that. Again, high volume centers, places that do a lot of this surgery are the best place to get an opinion and then potentially get a procedure. And I've definitely run out of time. So thank you so much, and I'll hand it back over to Dr. Manley.
So we got a couple minutes for Dr. Hayes. He'll be around this morning too, so if any of you guys have questions, feel free to go up there. But real quick, before we get on to our next one, if anyone has any questions, this would be a good time for Dr. Hayes. All right. Everyone's still drinking their coffee.
Yeah.
All right. He'll be around. So thank you, Dr. Hayes, very much. All right. Next up is Dr. Thomas. Dr. Thomas is a radiologist here. We were lucky enough that she was here, and she left and decided she missed us too much and came back. So we're really happy that she's here. I've seen this talk many times before. It's an amazing talk. So I really hope you guys get something new out of it. So Dr. Thomas, we'll have you come up. Thank you.
Good morning, everyone. How are you? I'm Kerry Thomas. I am a diagnostic radiologist, as Dr. Manley said, here at Moffitt Cancer Center. Just want to thank Dr. Manley for the invitation to speak to you all today, as well as for the Kindney Cancer Association and the Judy Nicholson Foundation for holding such an amazing event. As disclosures, I don't have any financial relevant disclosures to this talk, but let's get started. So my first question is sort of just a quick show of hands. How many of you have read your radiology report at some time? Most of us, right? How many of you understood what it said? Right. So that's what this talk is a little bit about. A little bit of that translation. And just again, I guess this is a disclosure of sorts. When I went to medical school, I didn't know I was going to have to learn a new language. We call it medical terminology. Lots of words based off of Greek and Latin that for most of us don't make sense until you learn them. Okay, fine, I learned that. And then I chose to be a radiologist. Little did I know I had to go learn a whole new language. And so if you read a report and you say, this is like all Greek to me, chances are it's because it is in words that are really specific to specific imaging modalities. So it's one of those things as I look back and now I take it for granted because I've been speaking this language for over a decade, but I recognize that it can be very confusing to people who are just taking it kind of on its face of there's words on a page. So hopefully we can clarify a few of those things today and happy to answer any questions at the end. So firstly, we want to talk about, well, who's who on the imaging team? When you come get your imaging scan, there's a whole lot of people that you interact with, right? And how that scan happens, where it's ordered, and all those other things. So the most important team member on anybody that's getting an imaging scan is you. You're the patient, right? You're directing your care. You're helping to make that informed decision of what scan you're having and why we're doing this. The referring provider, when we talk about that might be your primary care doctor. It might be Dr. Manley, who's your urologist, your surgeon, who's looking at a scan for surgical planning. It might be a medical oncologist if you're doing chemotherapy and we're doing a follow-up. It's the individual who ordered the scan. As a radiologist, I'm not allowed to order a scan for you. It has to be done by somebody who's seen you in the clinic and said, hey, this is why we need imaging. I'm the consultant. Similar to if your primary care doctor had you go consult with a heart doctor. Same idea, that's what a radiologist is. We're just the consultant on the imaging. So the radiology technologist or the sonographer, if you're having an ultrasound, that's the person that you're physically seeing when you're sitting on the scanner or on the ultrasound table. These are people who are specifically trained to perform the imaging study. They are not the person interpreting the images on the back end. So sometimes you might say, hey, can you tell me what you see? And they say, hey, I'm not able to do that. It's because they're not trained in interpreting the images. They're trained on obtaining good quality images. So they get sent to us, the radiologists, on the what we call the PAC system to interpret those images. So they operate the machines, they take the pictures, and our techs here at Moffitt do a really great job. And then the radiologist, that's someone like me. So we're the physician specialists. We've gone to residency, and here at Moffitt, we've all done specialty training and fellowship in specific areas. So I'm an abdominal radiologist. I did an extra year of training just sort of looking from here to here, where we have others who look just at the brain and spine, other people who just look at the extremities. So residency and fellowship in imaging interpretation. We are the consultant physician who interacts with the referring provider. So you might not talk to me directly, but I might be on the phone with Dr. Manley or Dr. Pock if one of your other surgeons here. So we interact when we say, hey, let's talk about this imaging study. We do, honestly, that's a lot of people say. We sit in computers in very dark rooms. I have to make sure to go outside to get my dose of vitamin D. Otherwise, I'm in a room with no windows all day because our images are interpreted in very dark rooms. So that's the other reason you don't see us very often, because in Florida it rains, and somebody said it rained all day, and I said, really? I had no idea. Okay, so let's talk a little bit more about the types of scans you get, right? Because that's another thing that can be a little confusing when somebody says, hey, I'm gonna send you for an ultrasound, or hey, you're gonna go get a CT, or today we're gonna get an MRI, and you're like, well, what's the difference and why? There are different reasons for doing different exams. So the ultrasound, hopefully this machine looks familiar to some of you. The ultrasound is an imaging modality that actually, the reason we call it ultrasound, it's not super creative, is we use high frequency sound waves. So it's ultrasound, and it actually creates images. So that thing that the sonographer holds and kind of rubs against your skin with the gel, that's actually creating sound waves, and the gel is acting as a conducer so that it actually creates those images. And ultrasound provides no radiation, so this is why perhaps a patient who is pregnant and we're looking at babies, we don't want them to be exposed to radiation. We use things like ultrasound. It's real time, so the sonographer is taking those pictures in real time while they're scanning you, and then they save images that get sent to us, the radiologist, for interpretation. Usually an exam, especially of most likely what you would be doing for a kidney disease, is a renal ultrasound, is about 30 minutes. So it's not a short study because it does take a lot of time to scan. No contrast is typically used. I say that typically because there is, it's been used in Europe and Canada for a very long time. There is ultrasound contrast. It's just been sort of a slow uptake here in the United States. It's a lot more involved, but it is an opportunity if somebody is unable to receive CT contrast to still be able to use contrast and look at it. The downside to an ultrasound, it's operator dependent, and it's limited in if you have difficulty moving, right? Or as we mentioned before, your kidneys are kind of between your ribs, those get in the way and create shadows. And so ultrasound is great kind of as a screening thing that we say, hey, I think I see something there, but we probably need to do something different, especially if we have any concern that it's a cancer, because we're not always able to definitively say what we're looking at. And then the other pieces that our surgeons are looking for in terms of surgical planning or making sure there's nothing in another part of the body, an ultrasound's not going to be able to do that for us. It's a very focused exam, usually on just one or a few solid organs. And so, but it's a great exam because it's widely accessible. Similarly, this look familiar to anyone? The donut hole with the bed? So this is a CT scan. A CT scan is great. It's basically a glorified x-ray machine. That is what it is. What's inside is there's a bunch of x-ray tubes in that circle that you're going through. And as a spiral, as the bed moves through, it's a big spiral. And it's just taking x-ray pictures the whole time. What's great about it is it is very accessible. We can scan your entire body in about 20 seconds. We eject the contrast, we turn on the machine, and off it goes, and it can scan the entire body. So this is why it's like really become the workhorse of imaging here in the United States, because we're able to take pictures very quickly and really get an entire view of your body. I always say that I can see the inside out, right? We see everything. So CT stands for, you may have heard it in the past, and many of us still say it, CAT scan. The A in CAT scan stands for axial. So way back when, actually, CT was invented in 1972, so it's really not that old of a modality. And at the time, we could only look at it in one plane, that sort of flat plane, so we called it computed axial tomography. Now we can look at it, we can cut you this way, we can cut you this way, or we can cut you this way. And so now we've gotten rid of the middle letter, and we just call it computed tomography, or CT. As I mentioned, it uses x-rays, so it does involve radiation. We can get a whole scan done in a few minutes, and what I mean by that is like the time it takes to put the IV and inject the contrast and scan you. And it may be one phase or multi-phase, so that's something that maybe when you're talking to your technologist and you're going to get that scan, you're like, hey, why am I going through the machine back and forth a few times? Is because sometimes, especially in kidney cancer, we want to see how that lesion may take up contrast based off of the timing. So it's actually based off of the cycle of how your heart beats. So when the IV goes in, within 30 to 60 seconds, we're really seeing it when it's the same color as what's in your aorta. Then if we wait like a minute to a minute and a half, we're seeing what it looks like when it's in your veins. And then we have it as a delay and want to see if it looks like when it goes into your ureters, when it goes down to your bladder. So that's what we mean by multi-phase, because different kidney lesions look different depending on what phase of contrast. So a lot of times if you're going, and you've heard of a 3-phase renal protocol, that's what we're talking about. We actually are scanning you through multiple phases of your heart cycle to see what those lesions look like. Typically uses, so it says may or may not. So we do have some indications where we don't give contrast. It might be if your kidney function is bad or if we're just looking for renal stones. But most of the time if we're looking for a kidney cancer, we do give IV contrast, and that is based with iodine. So this is something that may or may not be familiar. I know it's come out in the news recently, concerns about cancer and radiation exposure. That is a possibility. However, all imaging decisions are a patient-centered focus that we talk about the risks and the benefits of doing an imaging study. And so that's a conversation that all patients should be having with their physician about the risk of radiation exposure versus the benefit of having the scan. And so for example, if we need a scan to look to see if your cancers come back, that's very important than maybe avoiding, that's maybe more important than the radiation risk associated with having the scan. And one other thing I put on here, because sometimes it gets confusing when we talk about radiology, radiologist, radiology, oncologist, and it was mentioned radiation. So there's another specialty field of medicine called radiation oncology. So these are physicians who actually use high doses of radiation to burn tumors, to treat cancers. Radiologists use lower doses of radiation, and we're doing diagnostics. So we use the lower dose for the imaging pictures and the interpretation to make diagnoses. Radiation oncologists are actually using high dose radiation for treatment of disease. So hopefully that clears that up a little bit. All right, so MRI scan, this is another one. This may look familiar. It kind of looks very similar to the CT scan. But the difference between this that I usually ask people, have you had it or have you not, is it's super noisy, real noisy, and the hole is a whole lot smaller. It makes you kind of feel claustrophobic. So you may have had that scan. And they usually put something over your belly called a coil. So the MRI scan is another modality. It's actually really wasn't developed into the 1990s. But it's taken off in terms of how much better we've gotten with our image quality, our image resolution, really just within the last decade. So this has become an amazing resource for us as we do cancer staging and evaluation. What's nice about it is it uses actually magnets. So it's an important thing. It was recently, so it's a superconducting magnet. It's a giant super magnet. You can't walk in the room. So like if I go into the MR suite, I have to take this off. You have to make sure you don't have any metal on your body because it's a huge magnet. Things literally will get set up to the machine. But we use those magnets and we actually exploit the fact that our bodies are largely made of water, and we use the hydrogen from the water to actually create these pictures. It doesn't involve radiation, which is great. The downside of it is it's a very expensive scan. It takes at least 30 minutes, usually closer to an hour, so the availability is much less. We can't scan as many patients per day on an MR scanner. And what I mean by less availability, in big academic centers, we have lots of MR scanners, but in smaller areas, smaller community hospitals, in rural places, they may not have access to an MR. And in underserved countries, there are some places that may not have an MR at all. And so that's why we don't rely on this as a workhorse, because its availability just isn't there to be the standard of care. So that's why the standard of care typically is the CT scan. Always includes multiple sequences, takes a long time, and it includes contrast. We use gadolinium, so it's a different type of contrast that we use. Gadolinium is a metal. And this one's a little bit harder to tolerate, honestly, because it does require, we have to have you hold your breath for a period of time, as opposed to the CT scan, you hold it for about 5 or 10 seconds and we're done, where this requires a lot more of those things. But it does have amazing image quality when it comes out how we hope it does. All right, so now we're gonna talk a little bit about, let's talk about your report and go into the anatomy of your report. So I spend my whole life looking at anatomy, which I love, so I always kind of talk things about anatomy. So some terms are specific to the type of scan that's performed. So an ultrasound, when you're reading that report, you'll see us use words that say echoic, because we're talking about sound waves. CT scan, we're talking about x-rays, so those are densities or attenuation. And MRI, as I mentioned, because it's magnets, we're actually talking about how strong the signal from the magnet was, so in intensity. These are words that you've probably seen on a report, maybe not. So a cyst, when we say a cyst, that's telling our surgeons or our primary care doctors, this is a fluid-filled structure, it's benign, we don't have to do anything about it. Don't worry about it. A mass or a lesion, well, that could be one thing or another. So a mass or a lesion, it's indeterminate. It might be benign, but it could be abnormal. So for example, a cystic mass. Well, I told you a cyst is benign, but if it's a cystic mass, that means it has additional features that make me a little bit more worried. We do have types of kidney cancers, as was mentioned before, clear cell, but they can be cystic clear cell cancers, so they have some other feature. But a solid lesion, well, that sounds like it's gonna be a tumor, right? It might be, but it could be a benign tumor. So there's a benign renal tumor called an oncocytoma. So these are just word descriptors that we're using, that this is what it looks like on the images, but it doesn't necessarily tell you what it would look like on a microscope slide if they took it out. Contrast enhancement, sort of as I talked about before, is when we inject that contrast into your vein, it's watching how the structure takes up, it's basically the blood flow to the structure. So like a cyst, by way of example, has no blood flow at all. Where a typical kidney cancer is going to be very, very bright on a CT scan because it has a lot of vessels and a lot of blood flow to it. And when we see, if you see something like a collection, so maybe if you've had a surgery and then there's fluid that accumulates afterwards, we might call it a collection. That doesn't necessarily mean it's a bad thing. It's just very common that after surgery, our body just sort of reacts and creates these kind of fluid pockets that sort of resolve on their own, or if they get too big, we might drain them. All right, so anatomy of the radiology report. Some of these are pretty quick, so we'll just go through them. Examination title. So as we sort of talked about, this tells the provider, hey, this is the study that was done, right? Because so if you came from an outside hospital and you came to us and we got all your reports, we want to see what those studies were that they did. Did they do a study with contrast? Did they do it without contrast? Did they do an ultrasound? Did they do an MRI? So the exam title for us gives us a ton of information before we even start, so we know what we're dealing with. The accession number, that's really just an internal sort of auditing thing so that we can always find your imaging studies, specific date, specific time, right? If you've had several scans, just searching by your name makes it a little bit harder, but the accession number can go to exactly the day and time you wanted. Patient information, again, this is hospital to hospital, what's included on that report, but this is you. This is the information that's usually your name, date of birth, and your hospital medical record number. Clinical indication, this one's really important. So this is basically what your referring doctor is providing to me as the consultant of why they've asked me to interpret that scan. So Dr. Manley, for example, is saying, hey, this person has a renal mass and I'm looking at this to see if I can take it out surgically or if there's another option. Somebody else might go to the emergency room and have a CT scan because they have abdominal pain. So the referring provider is telling me, hey, I'm worried that this patient has appendicitis. That's what that clinical indication is. So it's your ordering doctor telling me, hey, this is why I'm scanning this person, so I can really make sure to answer the question that they're asking. It's also used, frankly, for billing and insurance, because this is often what is used for insurance companies to determine whether or not it's covered insurance indication. Comparison, so this is what we mean by this is, so this is the study that when I open a scan, I have all the studies from before of what I'm looking at. So we can say, hey, this looks the same, this looks different, or you had a mass in here that they've now cut out. And so the reason this is important, I'll just use a recent example. I read a scan over a weekend, and then I got a message from the doctor. Actually, the patient had had a scan in the interim. So I was comparing to an older study, but it alerted the doctor that, we were missing something. So they were able to get that interim scan and we could compare the more recent scan. So that's why it's important for us to let the referring doctors know this is the study that I'm looking at to say whether it's different or not. Technique, this is not something that our patients and families this is really more for, it's an accurate billing reason. It's exactly the study that we did. It helps me as a radiologist to say, oh, okay, I see that they gave contrast and I see what phases they did, but it's not something that usually our referring providers or our patients are reading. We have to put it in the report though, or it can't be, it's a billing thing. So findings, this is the part that you probably get to and you're like, whoa, there's a lot of words here. This is where you're gonna see those words that say cyst, enhancement, lesion. So this is the longest and most detailed part of the report. Most reports these days, I will say that there are still exceptions, but most radiologists and radiology groups have transitioned to what we call standardized reporting. So you'll see where I'll say liver, bile ducts, pancreas, adrenal glands, and so it's like specific line by line about each body organ. Most practices have gone to standardized reporting. It's preference of our referring providers and often our patients, so they can see, all right, I want to know what the kidneys are looking at, so I can go to the section on kidneys. We are bound to look at every image on the study regardless of why we're doing it. So if we're doing this to look at your kidney cancer, that's great, but it's also my job to look at all of your other organs. So that's why you're gonna have all that in your report. This is where I'm gonna say what's normal, what's abnormal. This is where I'm also gonna give information that maybe doesn't make sense. Why is that extra stuff there? But it's a surgical staging thing. So your surgeon knows, oh wait, okay, there's an extra artery here, so when they're planning for surgery, or whether it helps them understand their surgical planning. This is where I'm going to talk about chronic findings. So renal cysts, we don't have to do anything about, but if I see them on your scan, I'm going to report them. And then obviously abnormal findings, if they're present, this is where we describe them. So a lot of times there's a lot of words up top, and then you're like, well, how did that not make it to the bottom? Because many of that is, maybe it's not relevant to the clinical question, or it's been there before, it's benign, it's not something we need to worry about. And this is also usually where you're going to see where we're going to measure things. Oftentimes the measurements won't make it to the impression, but the body is where we'll put that. We also call the findings section, we also refer to as the body of the report, the biggest part. So impression. So the impression, this is really my opinion as a radiologist of what I kind of take it all together, what I think is going on with that scan. And that's what I'm providing back to you, the patient, and the referring provider, as sort of, you asked this question, here's what I think the answer is. So that's what we call the impression. And so that's sort of that bottom part that sort of ties it all together. And then that's, again, there's often stuff up in the body, but this is sort of the meat, the most important pieces. So that's the anatomy of a radiology report. I hope that I've been able to clarify a few things, and I'm happy to answer any questions you all have.
I belong with a big dorm that's got like over 5,000 kidney cancer patients. And one of the things that has been coming up more recently is the highs and lows of, you can hear me, right?
I can hear you.
The highs and lows of patients being told by the radiologist or the attending radiologist that everything's clear, and then going to their doctor appointment and finding out it's not clear, they have progression. So the emotional toll that it's taking, and we've had, in this group, we've had quite a few, and some of the questions they wanted to know was, can they ask a specific radiologist to always look, rather than have, because sometimes you see, like I get scanned every 3 months for 2 years, and I might have 10 different radiologists looking at it, and then we're seeing that they're missing it, and they're wondering what they can do to advocate for themselves, to better protect themselves, to not see this down the road.
Sure, that's an excellent question. The answer to a specific radiologist looking at a scan, most radiology practices and radiology groups have so many people, and we sort of take them by a work list. So by way of example, here at Moffitt, we have about 30 imagers that are body imagers that are reading all of the different scans. So there's not an easy way to filter for one person. I actually think it's great that multiple people are looking, because then you have different sets of eyes. I think if there's ever a question, so what I'm hearing is you said maybe the report says one thing, but then there's a discrepancy in what they're told when they see their referring provider.
Right, like some of these people are on trials, and it was their trial radiologist that said, oh no. And these were like 1 centimeter that were missed, so they're not small.
Right.
And so I think that's freaking them out, because then they're taken off the trial because the original radiologist or attendee missed it.
Gotcha. I think that's something that definitely is a discussion between, so if there is a question from the radiology interpretation and what the clinical provider is seeing, that perhaps they have that conversation between the two to sort of reconcile any potential differences.
Right, I was going to say, would they go back to the original radiologist and say,
yep, so
they would have a discussion with him?
Exactly. I mean, that's what happens here often. So if Dr. Manley orders a scan and I read it and he's like, hey, I kind of think maybe something a little different, he'll call me and say, hey, can we look at this together and sort of reconcile. And so that's certainly what I would encourage a patient to do if they feel like they're reading a report that says one thing and then they're told something different, say, hey, how do we get that fixed together?
Well, I was going to say, for me, my Dr. Manley is my doctor, and he encourages me for those second opinions. But I think sometimes patients are intimidated by the radiologist because sometimes they seem offended, and so they don't know what the next step is to take. Me, I'm just like, I want regret.
Yeah.
You know, but so that's one of the things that they're navigating, and we had in that group of 5,000, we had enough for it to be concerning.
Right.
So,
Well, and I guess what I would add to that is if, like you said, clinical trials, sometimes clinical trials are not, so we read our clinical trial patients here, but not all imaging centers do that. Sometimes they send their clinical trials out, and so it's actually maybe reviewed by 2 different people. And so that's where I would, as a patient, advocate that encouragement of have that conversation with your doctor so that they can go to the radiologists directly and say, hey, can we talk about this?
Okay.
I think sometimes radiologists get intimidated if a patient directly wants a report, because then they're not sure if that was already discussed with the referring doctor, and we want to make sure everybody's on the same page as a team. And so traditionally a radiologist typically interacts more with your doctor that ordered the scan, and so we want to make sure that they're aware of the question of you as the patient, and so that's maybe as a group having that discussion. Does
Okay.
that help?
yes, yeah, thank you.
I was wondering if you might be able to share the form or the resource that she has for patients.
He was asking if you could share the forum that you
Oh,
that you
it's a
have.
stage 4 kidney cancer on Facebook.
Thank you.
I think over.
I have 2, but I hope are quick questions. And one is, you didn't mention a PET scan on the scans, and the second one is about the role of artificial intelligence in radiology.
Sure. So I didn't include a PET scan, and apologies for that, as I guess I was being thinking about, this is what I read as an abdominal radiologist. We have a separate group of people that do PET scans. Yes, PET scans are utilized, but not typically initially in kidney cancer because they're not as sensitive in initial. So PET scans, so a lot of people hear, hey, a PET scan shows everything, but as we've talked about, PET scans are specific, there are specific cancers that they actually aren't very sensitive for. And an initial kidney cancer is actually, well, kidney cancer in general is one of them, and the reason is they inject a radioactive tracer, which goes right to your kidneys, so we don't, normally, right? So we don't know if it's normal or abnormal. Where a PET scan would come into play in a patient with kidney cancer is somebody who has cancer that's spread to other parts of the body, and we're following it there. So for example, if you have tumor in your lungs from your kidney cancer, a PET scan is probably going to be something that's utilized in that follow-up. But for example, in a patient that has initial, like if we're planning surgery or something for kidney cancer or bladder cancer, we're not going to do a PET scan for that because honestly, it's because of how the PET scan works. But if you've had it spread to other places, that's where a PET scan might come into play. And we're actually developing new PETs, so not that this is related to this specific forum, but there's a new type of PET for prostate cancer that has proven to be amazing, right? But it's really intended for recurrence after initial treatment. So hopefully that answers. The answer to AI, it's very interesting. It's like the vast majority of AI programs in medical imaging or in medicine are actually related to radiology. But as radiologists, we're still looking for them to really show where they're going to show that stride, whether it's going to be workflow efficiency or things like that. Some of them are sort of great, but what we've also learned is, and I'm not an expert on it, so I don't want to misspeak, but I've heard other talks, some AI actually creates things that doesn't exist. So that could be really scary, right? Like it sounds perfect, but then if you actually look at the pictures, they call them hallucinations. Now, I don't know how often that is because, like I said, I'm not an expert in it, and so right now it's not standard practice that AI is being used for image interpretation because it's still in a learning, because AI is trained on learning, so it's a matter of making sure. There are some programs that a lot of AI software is showing a lot of progress. It has started to kind of get a foothold. We're even evaluating, there's so many programs out there, we in our department are evaluating which ones are going to be the ones that are actually going to make this work better for us too. And so that's the other thing. There's so many. It's understanding what's the right one. So AI definitely has a future in radiology for sure. As radiologists, our volumes and anybody, guys, you can see that it's taking longer and longer to get your scans read.
Yeah.
It's because there is a national shortage of radiologists and the volumes have continued to increase, that there are just not enough people to interpret the number of scans being done. And so it's taking long. And so is AI going to be the way to help get this done faster? Because the number of people coming out of radiology residency hasn't grown, but the number of people getting imaged has.
Thank you.
Of course. Yes.
I want to thank you for this wonderful presentation. My name is Vincent. I'm a student from Tampa Medical College. I have just one question. It concerns one particular scan, that is the MRI scan. So I wanted to know, since something is a dye which is introduced into the patient before doing the contracts, is there any pre-counseling exam that you tell the patient to have, since something will be introduced into the patient's body before doing that exam? Is there any pre-counseling you tell the patient? Because some patients, for example, I'm taking an example of myself, that was done to me, I never knew what was done. That was introduced into my vein or into my arteries before that exam was done. I was doubting, if this goes into me, what will happen with me? So is there any pre-counseling you tell the patient to prepare the patient before that exam is being done? And if that exam is being done, is there any sign and symptom, anything you feel in his body after the exam that he has to sustain for some time before it is being neutralized or balanced?
So I just want to make sure I'm understanding your question. Are you talking about a contrast injection, or if we have?
Yes, I'm talking about the contrast,
Yeah. So we do typically have, it's a counseling, there's a lot of education related. So on CT scans, we give iodinated contrast. On MRI, it's gadolinium. And the technologist typically will share with you what you might feel. Honestly, most people don't have symptoms when they get a gadolinium injection because we use very, very small doses. CT scan injections, for those of you that may have had them, I've had a CT scan myself in the past. It makes you feel really warm on the inside. Sometimes it feels like there's metal in your mouth, might make you feel like you have to use the restroom. Typically people for MRI scans in gadolinium don't have similar, and we think it's related to the smaller dose. Now, if you do have symptoms after the injection, it's very important that you notify the technologist, because they're very rare. MRI is actually less rare than CT contrast, but you can have an allergic type reaction to those contrasts. Like you can have an allergic reaction to any medication that, you might have an allergy to it. So they are rare, but they certainly do happen. So if you feel unwell after those injections, it's very important to share that with the technologist so that the radiologist on site can come evaluate you and determine if they think you're having a hypersensitivity reaction to the contrast media.
Thank you.
Yeah. Does that answer your question?
Yes.
Okay. And just for MRI too, you will, if you do ever have an MRI, and just for any of you that might wonder, well, why haven't I gotten an MRI? There are some contraindications to that, because as we mentioned, it's a superconducting magnet. So if you have certain body internal fixation hardware, if you've had clips in your brain, or if you maybe have had shrapnel for some reason, that might be a contraindication. So it's something that needs a discussion. In the past, pacemakers were a contraindication, but we do have some pacemakers now that are what we call conditional. So depending on what your pacemaker is, you may or may not be able to. So that's another thing for MRI. And we always screen you. We actually, here at Moffitt, it's basically a metal detector when you walk into the room to make sure that you don't have something that could cause an issue with the MRI scanner.
Thank you, Kerry.
Thanks. Thank you all for the opportunity. If you have any questions,
I think it's important to just mention, a lot of patients, and many of you in this room, see the providers that are your treating physicians, your surgeons, your medical oncologists, but, part of the team that you don't see often is people like Dr. Thomas, the pathologist. Those are the people that really make for the excellent care here, right? I can't tell you how great it is to know when our radiologists are really looking over scans, giving that extra detail, giving that extra insight, and same with the pathologist. So, just for all of the patients, know that, your treating physician, right, that's the quarterback of your team, but there's many more players that are helping you along the way. All right, we'll keep going here. So Aditi, I'm going to introduce next, who's going to talk a little bit about systemic treatments. We've touched upon some of the local treatments with Dr. Hayes. We're going to start expanding a little bit here into those who need systemic therapy and what those options are. Thanks.
My name is Aditi Patel. I'm one of the PAs here in the Medical Oncology Division of the GU Clinic, and I'm going to be talking about adjuvant therapy for patients with kidney cancer. So we're going to talk about what general treatment options, what the immune system is, and what its role is here. When do we do immunotherapy after surgery? Who is this applicable for? What are the side effects? What does being on treatment look like? And then what if that isn't the right choice for a patient? So to start talking about adjuvant therapy, we have to know what that means. So adjuvant refers to treatment that's given after surgery. You may also hear of neoadjuvant therapy in some cancers, and that's given before surgery. But here in kidney cancer, we're giving adjuvant immunotherapy within about 12 weeks of your surgery to reduce the risk of recurrence. So look, in general, when it comes to cancer, you often hear about things like chemotherapy, radiation, surgery. Chemo isn't one that we use as often for kidney cancer, and there's other things like targeted systemic therapies that we use that we'll talk about more later today, but also immunotherapy. So how did we get here when it comes to kidney cancer? There were a lot of different studies done in the past to look at different treatment options that could work before a patient has metastatic disease to see what would be a good choice. And these, on the right side there, they're showing different, it's a whole list of 7, 8 different studies that were done in the past, usually using drugs that we used in the metastatic patients. But most of those studies didn't show reduced risk of recurrence. In 2016, there was a study using a drug called sunitinib that did show improved disease-free survival. And it was used some, but that particular pill did have a lot of side effects. Patients, it was harder to tolerate. So in 2021, there was a new approval from that trial called Keynote 564 that looked at pembrolizumab, an immunotherapy, in that post-surgical time period to reduce the risk of recurrence. And that was a big game changer in this field, and that's now what we use as standard of care after surgery. So when it comes to the immune system in general, the immune system is a complicated thing. It's made of a lot of different organs, tissues, cells. When we talk about cells, there's your white blood cells. So looking at that picture in the bottom middle, your lymphocytes specifically, those are ones that can attack different pathogens and also attack things like cancer. So that's key to how immunotherapy works that we're putting to use here. And immunotherapy in general is a broad category of treatments. There's different types. Specifically, when it comes to this kidney cancer adjuvant space, pembrolizumab is what we call an immune checkpoint inhibitor. But we often just broadly call it immunotherapy, so you may hear those interchangeably. So later in this morning, you'll hear in a little more detail the mechanism, but I'll give you the broad overview now of how immunotherapy works. So your body has its own immune system to help figure out what belongs to the body that shouldn't be attacked and what's foreign material, whether it's bacteria or cancer that the body should be trying to get rid of. The cancer has ways that it uses to try to essentially hide from the immune system and stay in the body, keep those lymphocytes from attacking the cancer and helping destroy those tumor cells. But with this immunotherapy, we're able to take advantage of that drug to prevent that hiding of the cancer cells. So then the body is able to go out and attack cancer. So things like chemotherapy you may hear of, that's directly killing cancer cells. Here, immunotherapy is telling your body to go out and do that work. So that's a little bit of that difference there. So immunotherapy is relatively new. The first one was approved back in 2011, and we've had several approved since then. And pembrolizumab, or Keytruda, its brand name, that was one that came out in 2014. And all of these are used in different cancers, sometimes multiple, sometimes in combination with pills. But the only one that we use after surgery to prevent recurrence is going to be pembrolizumab. And this is just another similar diagram to prior. So this study, Keynote 564, what this was is that they compared patients who received a placebo to people who received pembrolizumab for 1 year after their surgery. This wasn't given to every single patient who was diagnosed with a kidney cancer. It had to be clear cell renal cell carcinoma, and they were giving it to patients who were thought to be at higher risk of recurrence. That's decided based on features seen in your surgery and on the pathology, what that cancer in the tissues actually looked like. And so there's a lot of complicated things on there, but if your surgical oncologist decides that your cancer was a higher risk cancer, then you may be referred to medical oncology to talk about immunotherapy afterwards to reduce your risk of the cancer recurring. Additionally, this also was used in patients who had one site of metastasis. So often we see, like, say, adrenal gland metastases close by that's able to be removed as well. So then these patients, yes, they had some metastasis, but it was removed, and they're on scans, they're what we call no evidence of disease. So in them, they were also included in this study. And so looking at outcomes, we now have data from several years out from this study. And so the bottom bar going across is showing you number of months, basically at 1 year, 2 year, 3 year, and 4 is those highlighted portions. And then on the y-axis is showing disease-free survival, so people who don't have any recurrence of their cancer on scans. And you see that not just initially at the 1 year mark, but continued throughout. The upper bar is, the green is showing people who received pembrolizumab and that they have less rates of recurrence than people who did not receive treatment. Additionally, when they did further subgroup analysis, they saw that patients with the higher the risk, especially those who had that one site of metastasis they were able to take out, that they had even bigger benefits from this therapy. For example, it showed that at 2 years, 37% of the patients with some smaller metastasis that was removed had recurrence if they received no therapy, compared to 78% remaining disease-free at 2 years if they got this 1 year of immunotherapy. So overall, immunotherapy is generally pretty well tolerated. Though, when you're telling your immune system to go out and activating it, essentially releasing some of those normal breaks, you can have side effects. And these are a little bit unique in that it can cause inflammation anywhere in the body. So when you see that ending on these words, itis, that's referring to inflammation. So you can have things like dermatitis affecting the skin, colitis of the colon. You can also have things like inflammation of the liver, your lungs, anywhere in the body really can have inflammation. So we keep a close eye on side effects in labs when you're on treatment to watch out for these things. Often these are very manageable. We're often able to continue therapy and just manage it with medications or small adjustments. But there can be serious long-term side effects that aren't going to resolve when you finish immunotherapy. For example, if you develop inflammation of the pancreas, you can develop what we call type 1 diabetes, where you're insulin dependent long-term. This is different from what you yourself or family friends may know people with type 2 diabetes, where through diet and exercise and medications, they may over time be able to reduce the need for meds. For them, even after they finish immunotherapy, they're still going to remain needing insulin long-term. So immunotherapy is really good, really well tolerated, but you do have to know that there are risks of more serious things as well. And each immunotherapy drug has some particular things that are more common with it than others. When we look at the category that pembrolizumab belongs to, we often see initially, early on, things like colitis, so that'll present with diarrhea, or dermatitis, so rashes, itching, things like that. And those often happen earlier on. But you'll notice on this graph it's showing a number of weeks. At day 1 or 2 after your first infusion, or even week 1, 2, 3, you often don't have many side effects. Some of my patients say, maybe I was a little bit tired for a few days after, like a day after. But these side effects don't happen immediately the way it may happen with chemo or even drugs that you may take for other non-cancer conditions. So immunotherapy being longer lasting means the side effects can present at any time during treatment, but often takes a little bit before you start to see those side effects. I'll go through a few of the common ones that we see, just so you have a sense if you go through immunotherapy of what we may be looking out for. Diarrhea is one that I see commonly. Not everybody gets it, of course, but a lot of people do. And often it's just as simple as a little bit of a few loose stools per day. And often it's very manageable. Some people don't need any medications. Sometimes, though, we may use anti-diarrheal medications like over-the-counter loperamide or Imodium, which some of you may have used in the past yourselves. If it's more severe, though, we may need to, say, hold immunotherapy and even give things like steroids or other immune-modifying drugs to help essentially stop that activation of the immune system and the effects on the colon. Another really, really common one that I see is rashes and itching. These often are very mild. We use things like topical cortisone creams and then some antihistamines like your Zyrtec, Claritin, things like that to help with the itching component. And people do really well with that. Sometimes, if it's more severe though, we may need to hold therapy. Even sometimes the rashes can be severe enough to be really significant, need hospitalization for more IV steroids and closer monitoring. So that can happen. Often just manage outpatient through simple medications. And then hypothyroidism is a common one that I see on labs. It happens when the immunotherapy causes inflammation in the pituitary gland, which helps downstream regulate your thyroid gland. So if your thyroid gland stops producing its thyroid hormones that it used to produce, you will first start to see changes in labs, and often we catch it there before patients even develop any symptoms. Sometimes they may have symptoms which can be feeling a little more fatigued than they used to, having some dry skin, constipation, maybe noticing some weight gain or feeling more cold easily. And the treatment for this is giving thyroid hormone in the form of a pill. It's a common medication. Many of you in this room may even have taken that even before having kidney cancer. It's a very common thing. So it's very easily managed, but that's often a long-term medication, even after immunotherapy. So you heard me mention steroids a few different times here. Steroids work because with how long-lasting immunotherapy is, its effects don't leave the body within a few weeks or even months, even after your last dose, if we say hold a treatment because you're having some increased side effects. We have to find a way to essentially calm down the immune system, and we do that with higher doses of steroids. Often it's done with oral steroids like prednisone, but sometimes you may have to be in the hospital to get some IV steroids initially. And so when it comes to steroids, that comes into the picture here when we're thinking about people who come to us who have a history of autoimmune diseases. These patients, they at baseline already have a disease where their immune system is a little bit dysregulated. It's already attacking their own body. So we don't want to give them immunotherapy and cause worsening of their underlying autoimmune disease with this medication. So sometimes in those people, they may already be taking things like steroids or immunosuppressive meds to control their autoimmune disease. Immunotherapy would be counteracted by those high-dose steroids. So if you have a history of an autoimmune disease and then need treatment with immunotherapy, we may say in this adjuvant setting that that's not the best option. Let's just monitor you with scans every 3 months instead, or periodically, rather than giving you therapy. Since, as you saw in those graphs, a lot of people who have their kidney cancer surgically removed don't even have any recurrence. So what does that 1 year of treatment actually look like for patients? It's generally an infusion every either 3 or 6 weeks. Most often we do every 6 when it comes to adjuvant therapy. You get labs before each dose. You come to clinic, we go over those labs, any symptoms you may be having, make any adjustments as needed, and then clear you to make sure that yes, you are safe to receive this infusion. We encourage our patients to reach out to us with any symptoms they're having, whether they're ones that we've talked to them about before, that hey, immunotherapy can commonly cause this, keep an eye out for it, or things you're unsure about. It's always better to reach out to us and ask, is this something I should be concerned about now, or is there anything I can be doing? We'll do scans even during this year of treatment to keep an eye on things and make sure that there's no evidence of the cancer recurring, no changes we need to make. when it comes to that 1-year treatment, you usually don't have any activity restrictions. My patient is still able to stay active, work, do most of their usual things without any major impact. So that's a really beneficial thing about immunotherapy and pembrolizumab. These side effects, we talked about being long-lasting, often will give you these little wallet cards for you to keep that say that I'm a patient who's been receiving this medication, so that if there's ever, say you go to the ER for something, or say you're not coming to your regular doctors, regular oncologists, people outside can know that, hey, I need to think about this as well. It's maybe potentially causing whatever's going on. So overall, pembrolizumab, Keytruda, is recommended for adjuvant therapy in certain patients depending on characteristics after surgery. But if for whatever reason you choose not to do immunotherapy to prevent recurrence, that's also very reasonable. And we just continue with surveillance scans. And there's still ongoing research happening into additional adjuvant therapy options and other ways to try to manage this going forward to get even lower rates of recurrence. We can take any questions now. Thank you.
Any questions? Yes. Donna has been recommended next for 3 letters. I'm not sure what it is. The TB treatment, is that immunotherapy? There's a TB. She originally had a radical, she had her kidney removed, and apparently cancer cells are getting into the bladder now, and she's had the chemotherapy, and now they're recommending a 3-letter word that had tuberculosis.
Yeah, so I think you may be a little bit confusing in that you're talking about urothelial cancer that was in the kidney. And the patient had a nephroureterectomy, which is a little different than a nephrectomy. Does that sound?
No, it was removed, totally removed.
Yeah.
And cells got into the bladder now, and now the cells.
So that's a very common thing for urothelial. That's a different type of kidney cancer, so to speak. So everything that she just talked about, essentially everything today, will not be specific to that. That's a different type of kidney cancer.
No, my question was, is that immunotherapy?
It is technically an immunotherapy.
Oh,
correct.
Okay.
Yeah.
Thank you.
All right, thank you, everyone. So keep it going. Yep, give her a hand. All right. Next, we have Dr. Chahoud, who's a good friend, a close colleague. Many of the patients know that when you come to my clinic or come to clinic on Thursdays, we're all there together, which is great. I think a real benefit to patients, especially when you get into the more complex patients. It's really wonderful to have somebody like him, a couple seats down, and I sort of, just follow him around like a little puppy until he answers my questions. So Dr. Chahoud will give us some updates on some of the clinical trials. Obviously, a lot of what we talked about today thus far have sort of been the standard of care, introduction stuff, but one of the things, especially patients later in the disease course, that becomes an important part is the options for clinical trials. So having some knowledge about that, because they can definitely be a little intimidating on the patient level, because I think the involvement by the patient becomes a lot more, but certainly you shouldn't shy away from that, and hopefully some of the information Dr. Chahoud shares makes you a little more comfortable to have that conversation when you're ready. All right, thanks, Dr. Chahoud.
Thank you, Brandon. Thank you. I will start by thanking Brandon, Epi, Karen, and everyone who got us here together today. And thank you all for coming, including the pups. One of the things that is important as you go on your journey is this word of clinical trial. So there is a lot of dogma around it, there is a lot of complicated stuff around it, admin, care, clinical care. So we'll try to go over kind of what is a clinical trial. So what is clinical research? So basically it's a study that involves people. And then we're either trying to treat cancer or find and diagnose cancer earlier if it's an imaging modality, new imaging modality, or to prevent cancer from the beginning of happening or reducing the chance of it coming back. It could be also managing symptoms of cancer treatment. So you may hear when a doctor is talking to you about clinical trial, the word phase 1, phase 2, phase 3, phase 4. So basically a clinical trial, the way I see it, is another tool in my toolbox. So we have the approved option. Aditi did a great job talking to you, for example, about an FDA approved option for a patient in the adjuvant setting. That did not happen if it didn't go through a phase 1, phase 2, phase 3, and then gets FDA approved, and then it goes to the patients. And part of going through phase 1, generally, and the old definition used to be defined as safe and effective dose, basically to treat the patient. So it's the first in human. They've done on this drug lots of preclinical work. They tested it in mice, they tested it in monkeys, they tested it in vivo models of that specific tumor that you have, and it looks great. But if curing cancer in mice is the same as in human, we would have cured cancer probably 50 years ago. So it's not. So you need to take it back to the humans. And the first phase is to make sure that this thing that you've studied the pharmacodynamic and its safety profile and its efficacy in animals, and now you have to test it in humans. So that used to be the old definition of a phase 1. So patients, when they hear the word phase 1, the reflex to them is like, am I going to be a guinea pig? I hear that all the time in my clinic. And I answer it in this way. Phase 1 are becoming more and more phase 1 plus phase 2. What does that mean? A lot of work in industry and with scientists is becoming more and more focused, where that phase 1 early development molecule, whatever treatment it is, it's being more considered thoroughly to a specific tumor. For example, in our situation, RCC. And now when it comes to me, as a PI, as a doctor, when I'm picking my clinical trials, I'm thinking of adding tools to my patients' options. And the way I think of that is, okay, I want a phase 1 molecule that has great preclinical data, a great biological information, but it's also specific to my kidney cancer patients. So I want the industry partner who's developing that molecule having, most of the time, hundreds of millions and billions of dollars planned to develop that molecule in that specific disease. So it makes more sense for us to pick that and have that tested. And phase 2 is more to evaluate efficacy in a smaller portion of patients. So phase 1 can help you with around 50 to 60 patients to test the safety. So you know the best dose to give. And then the phase 2, you treat another 100 to 200 patients to see what we call a good signal to then take it to a phase 3. And a good signal could be tumor shrinkage, patients living longer, and then that takes it to a phase 3 where it's more rigorous. And this new molecule that has gone through phase 1, phase 2, now it's being compared to whatever the current standard of care is. For example, we can take the example of Keynote, that data that Aditi presented with adjuvant immune therapy. So now if they want to approve something better than immune therapy with Keytruda, whoever is developing that molecule or that doublet or whatever, they have to go against it in a randomized controlled trial. Randomized means that we don't pick, the computer picks who gets Keytruda alone and who gets Keytruda or the new drug that we think is going to become the new standard of care. So basically, they go head to head in a powered study of usually 1,000 patients to prove a primary endpoint, which is most often either what we call overall survival, which patients living longer, or progression-free survival, which means patients living a longer time without having that cancer get worse or progress. And we pick that endpoint sometimes as a shorter endpoint so that we don't delay active therapy that is better than standard of care from getting to the market outside of clinical trials. And phase 4 is when the FDA continue following those phase 3, approved drugs to make sure that in the real world there is no bad signal of efficacy or bad signal of safety. So clinical trials, accruals and participation, I think it's a major opportunity for US in general, every academic center and every non-academic community cancer center, everyone who's treating cancer patient that should be our effort to improve that 2 to 3% of patients diagnosed with cancer participating in a clinical trial. As I told you, clinical trial can span from a phase 1 to a phase 4. Clinical trial can go from diagnostic, preventive, therapeutic, early disease, adjuvant, advanced. We only have 2% of patients getting the opportunity to get another tool in their toolbox that could help them get another shot on target and live longer. Many factors, it's been studied, we study things in science, unfortunately we end up with a lot of results, implication and improvement tend to require money, and if you don't fund research and change, it's a big barrier. So attitude and mistrust of researcher institutions, I think that's also on us as physicians to have time to explain what is clinical trial and what is the specific clinical trial you're being considered for and what does that mean for you. I try with my patient and a lot of, I see some familiar faces here, is like I try to empower my patients on that decision and I tell them it's a shared decision. We're gonna sit here, we're gonna look what is standard of care, what are our options, and what does this trial mean to us? Is it gonna add anything? Is it the right time for us to go on it, or is it not the right time? And that takes into account a lot of things. That home situation, whether they can come more often to the clinic, that disease situation where I cannot afford phase 1 study not working. We need to get something that is more approved to get it controlled early on. This study itself, if it's adding a third drug to approved doublet, for example, and I have a young patient who wants to do more, then that's a no-brainer. It's more about us working with the patient. It's more on us than the patients. We've been oncologists definitely more than the patients has been a cancer patient. And it's more on institution having the capacity to offer a lot of clinical trials for every patient. And that's something that I'm going to be talking to you with kidney cancer. Concerns about cost. Having to come to a cancer center on its own is more expensive. There is travel, gas, parking, taking day off. So it's a couple of $100 every time the patient decides to make one visit. Not all of us think about that, and it's important. A lot of the industry-sponsored trials are supported by the industry for transportation and lodging, and that's an option that all of you should always ask. Does the study support travel, transportation, and lodging? Most of the industry-sponsored studies will. So that is a barrier that could be taken out. Being non-English speaking, unfortunately, I'm Moffitt, like all of my trials have at least 2 or 3 languages translated to, so that's not even a barrier for the majority of our patients, but you have to translate all of the consent form, protocols, and have them ready to offer them in the native language to the patient, because that's on its own pretty complicated, and it's on its own can get much better. We give patients 20 pages of consent forms with what we think is patient-specific verbiage, which can get much better. It could be done in 2 or 3 pages, but trying to put legal and patient advocacy at the same, like if it was for a patient advocacy, we probably would have it condensed into patient, which would be what I would like, but legally, institutionally, you have to explain everything and all the risks so you cover yourself. So telling you a bit about how I think of clinical trials. When I joined Moffitt 6-7 years ago, we did not have one open clinical trial for kidney cancer, 0. And my goal was to as I think of it, is at every time point of the disease, have at least one option. So you can see in the adjuvant setting, which Aditi talked about, we have a clinical trial that was a phase 3. Now you know what the phase 3 is. So they're trying to beat the standard of care. They're trying to beat Keytruda by combining it with belisiprazole, Welireg, another FDA-approved drug. So it makes sense. So that's why I personally picked it to be in my portfolio. Because what is the worst case scenario? The worst case scenario that I explained to my patient is that you will be blindly randomized to either Keytruda, which is what I would give you, or Keytruda plus Welireg. Welireg is already approved for kidney cancer. We already know it works. We already know the safety profile of it. It's already been combined with Keytruda, so safety-wise it's also safe. So it's more or less a win-win situation with low risk. And that's how I think of picking up my portfolio for my patient. It's not a portfolio for me. It's a portfolio for whenever a patient comes in the door to meet me, is for me to have the opportunity to talk to them about one more option in their journey. So first line is when the patient is diagnosed with stage 4 and has not received any therapy yet. So first line is basically you have not had any therapy. So we try to combine. So we currently have an adaptive therapy that we're going to be talking about briefly. So it's basically a standard of care approved option, but we give it in an adaptive way. And we'll talk more about that. We're trying to get funding from N01 for an in-house still therapy that we're not going to be talking about more today because we don't have the funding for that. So if you know any billionaires or millionaires that can help, that would be awesome. So basically, briefly, it's taking nivolumab and ipilimumab, which is Opdivo and Yervoy, approved, FDA approved. And what we're doing, we have our in-house TIL therapy, T-cell. Basically, we take the patient's T-cell and we expand them and we give them back to the patient. So we optimize that in our in-house labs here at Moffitt. That's something that Moffitt specializes in with Dr. Shadi Thomas, who's a brilliant immunologist. And we can make better TILs. And that goes into the way of thinking of the way you can improve immune-resistant therapy is given it in a different way. So these are different way of doing immune therapies. But that trial is not available at this time point. The other trials that we have in second line, we had, is basically, the first one is an example of a question that is only technically interesting for us physicians and patients. Is two approved drugs, cabozantinib and lenvatinib and everolimus, both have already FDA approval. Both are approved in second line, third line. They have never been compared head-to-head to see which one is better, or if any of this is inferior or not. So this is a study trying to answer that question, and that study will be presented at ESMO this year. And then Schneider 02 is another way of trying to improve currently FDA-approved options by not only trying to find other ways of doing immune therapy better, but finding another way of doing VEGF TKIs and targeted chemotherapies better with a drug called zenzalitinib that is being explored in kidney cancer, but in other therapies. And I also focus on novel therapies where, as I explained to you, I want first, second line therapies to be as strong as possible, or adjuvant as strong as possible. But when the patient has gone through multiple lines of therapies and they're still physically well, doing well, but they've used almost all of the approved therapies, we have to look for good phase 1, phase 2 studies, which we will be, in my mind, it's going to be either improving immune therapies or improving TKIs and HIF-alpha inhibitors in the next 5 years for kidney cancer patients. Those would be things that will probably move the needle in the next 5 years. Better immune therapies, better cytokine therapies. So the first phase 1, phase 2 is a modified IL-2, which is an old drug that is FDA approved for kidney cancer. The second phase 1 trial that will be open is a bispecific NK cell targeted therapy. So basically it's going to be a first in human trial that tries to focus on the NK cell, which is a form of immune cells in our body that we have not focused our immune therapy angling on before in the past decade. Now it is a focus in the last 5 years of drug development. So it's interesting because none of the options that are FDA approved in kidney cancer target that specific aspect of the immune system. And then you'll see in the last column is a couple of trials. The first one is a trial called TRAVERSE. So these are CAR T trials. I'm sure probably you've heard about CAR T therapy in malignant tumor, in leukemias, lymphomas. So they're trying to take the same technology, same mechanism of actions, but trying to target CDs that are expressed on kidney cancer patients. So CD70 is a target and CA9 is a target. The CD70 is a target for the first molecule, CA9 is for the second. So this is our adaptive trial that I talked to you about. So what does it mean? So we have very smart mathematician at Moffitt that do mathematical oncology. And they have a way of calculating using formulas what is the optimal way of when to stop therapy and when to continue therapy. Because right now, the way we develop phase 1 drugs is the maximal tolerated dose until the patient says no more. As long as the therapy is responding and you don't have severe side effects, we keep going. So the adaptive approach is we give an FDA-approved treatment, pembrolizumab, Keytruda, and Inlyta for first-line patients, and we follow them. If they have a good response on the scan with more than 20% shrinkage in all of their target volume, we tell them, let's take a break. Let's stop the therapy, both. Therapy has a lot of side effects. So we follow them with scans. And as long as the tumor does not go back to where it was when we started, we keep them on break. And then when it goes back to where it was, or a bit larger, we restart. So it has clonal evolution theories in it, mathematical oncology theories. Basically, you don't put too much pressure on all of the cancer clones and you select the bad clones early. So that way you are killing some of the bad clones and some of the good clones and keeping the good clones of cancer to use as well some of the nutrients to grow. That way the bad clones are not using all of the cancer nutrients to grow and grow faster. And the patient is getting a better quality of life by being off of this medication. And again, it's these kind of trials are not industry sponsored, so it's not interesting for a pharma company to do these sort of studies because, again, why change the general way of doing things, and it doesn't make sense to stop the drug and do less drugs. So these are either grant funded through internal efforts in Moffitt or the ACS. So we're hoping that we're going to generate some good data with good patient-reported outcomes so we can get more funding to offer it to more patients in the future. This is the data of STELLAR-02. This is another example of how you can do therapy to try to improve some of the already available assets with an immune therapy and a VEGF-TKI. So it's looking at a new VEGF-TKI called Zanza in kidney cancer patients. And this combination has shown an overall response rate of 63% and a good median duration of response. And it's being considered by the study sponsor for future evaluation in RCC and other tumor in more advanced stage. So this is TRAVERSE. I wanted to highlight this trial for you. This is a CAR T trial that we have here at Moffitt, and it's probably going to be moving more beyond this phase 1, phase 2 stage in the future. So basically we've treated 50 patients, and this is allogenic CAR T, so off the shelf. So we don't take anything from the patient, it's off the shelf, specific CAR Ts that target CD70 in patients with kidney cancer. So we test them just for HLA. If there is HLA compatibility, we're good. We get the product shipped from the company, and we give them, what you're seeing here is FC, is we give them some chemotherapy before we infuse to bring down that immune system from kicking that CAR T out of their body. And then we give them that CAR T, and basically what you're seeing on the spider plot is the tumor shrinkage. So when it's at 0, that's where we're starting. And when it goes down, it's how much reduction you've had by percent. So you see here, patient, the first one, and I have a pointer, but the patient that's first here dropped around 70-80%, another one dropped to 45% in their tumor. And if you can see, that patient who dropped it got 1 CAR T infusion, and it's been lasting, that response has lasted for more than a year now. We've had around 44% response rate in patients who express CD70, and all of these patients were heavily pre-treated. So on average, those patients have already seen 5 therapies. So this is the majority of those patients who are responding and getting a year of durable responses are patients who already have gone through most of the standard of care approved options. This is a nice image. It's always nice to see actual responses from a patient. So that's the kidney mass. You see where the arrows are. That's at baseline, and that's his kidney without the mass after 1 month. So with that, I will leave you. And if you have any questions, please go ahead.
So I assume that big pharma companies have research and development of their own. And I'm trying to understand the role of the academic physician researcher and the pharma company and their in-house research.
Okay, so do you watch basketball? So Phil Jackson has the triangle of offense. So pharma, us, and the patient is the triangle offense in my mind. So the stronger these 3 are working together, the better of the flow of getting a clinical trial from R&D to the patients to approval. If you're having a break there, and we have lots of breaks in the system, in that offense, yes, that's a big portion of how we can do better between academia, industry. So basically, we rely a lot on research and development in all of the big pharma because they are what drives most of the science. 90% of approvals are stuff that's driven through research and development. And driving things that is academically driven is much harder to be done here. I gave you the example of the TIL therapy. We don't have $4 or $5 million to treat 15 patients to get that phase 1 even going. Research is expensive, and it needs that collaboration to make things go. I hope I answered.
Thank you.
Go ahead.
So I have a question. All the studies you showed are specific to clear cell carcinoma.
Mm-hmm.
Does having papillary carcinoma exclude you from those studies?
Yeah, so most...
Are there specific ones too?
So that's a very good question. So Study 02 had a non-clear cell arm, but the majority of these studies require clear cell histology, and that's a big gap. And it's being a rare cancer nerd, I do kidney cancer research and I do renal cancer research. It's even much rarer than papillary. It's a couple of thousands of patients in the US, 4,000 probably per year. So it makes clinical trials availability much tougher because one, the investment is not worth the return on investment from a money perspective, and two, accrual on these trials take longer because patients are fewer. So, but there's a lot of these pharma companies that have trials specifically for the non-clear cell. So same to the Study 02, there is now a phase 3 trial ran not at Moffitt but across the US, looking at that same molecules as in patients with non-clear cell RCC, and it's a phase 3 trial. So, and there are other options. So the best option for you to go is to find these, either to
KCA has a good list of, I'm not sure how updated it is, I haven't looked at it for a while, but it used to be updated. And or clinicaltrial.gov, and try to figure out the non-clear cell histologies.
Is the Magnolia campus the only one doing these clinical trials?
The majority of these trials are at Magnolia campus, but one of the efforts of Moffitt is to expand them in the future to all sites. So we have, our adaptive trial, for example, because it's standard of care and does not require a lot of complicated machinery. So for example, for these phase 1 studies, we follow what we call PK. It's a fancy way of saying we see how long the drug stays in the blood. And we follow them at 1 hour, 2 hour, 4 hours, 6 hours. So other campuses don't have the capacity to do that yet. But for example, the phase 3 trial, adaptive trial that we have, it doesn't have anything that's super complicated, so it's open at all the campuses. So it's trial dependent.
All right. Thank you, Dr. Chen. One more question.
Yeah,
Hold
so
your
you
phone.
say response rate, you're talking about percentages of patients whose tumors stop growing? Is that what you mean by response rate?
Yes, so it's the definition of the overall response rate is the percentage. So you have 100 patients, okay? How many of those will have a reduction of 30% or more in their lesions?
30% reduction actually.
A reduction. So it has to be 30% or more for a patient to be called a responder. And we look at that percentage overall.
All right, thank you.
Of course.
All right, now you can clap. All right, we're lucky enough to have Amy Schneider here, who I mentioned earlier this morning about the many people that patients don't get to see that go into taking care of you, and she is definitely one of those people. She's our pharmacist in GU, so she is an encyclopedia of every drug ever made and every indication. Some of you do get to meet her when you require systemic therapy and know that it's not just us, behind all the orders. You have somebody smart like her doing all the double checking, which is always an extra nice thing to have. So without further ado, Amy will give you some updates here on systemic therapies. Thank you.
Thank you. So I'm going to talk to you all today about some of the patient considerations in systemic therapy. So I'll highlight some of the main classes of medications that we use, but then also from a patient perspective, some of the toxicities of those medications and kind of how we manage those. So just in general, just know that whenever you're coming to clinic, we do consider all patient factors when deciding on your treatment regimen. Comorbidities are super important, so especially with some of the classes of medications we use, it can affect the heart, especially hypertension. It is one main side effect of one of the medications we use, so we do take that into consideration. And usually work closely with your other healthcare providers to make sure that this is managed very well. Liver disease can also impact things because a lot of the drugs we use are metabolized through the liver, so we'll always be checking baseline labs before starting you on any systemic therapy to make sure that your liver, your kidney function is good to start, and we'll keep a close eye on that throughout treatment. Autoimmune disorders are super important to let us know about, just because, as I believe my colleague Aditi talked about earlier, immunotherapy is one of the mainstays of treatment, and I'll kind of highlight some of the side effects of that as well. And obviously we consider age and performance status as well as patient preferences. Some people have the goal of having great quality of life and they don't care as much about length of life, where other patients care more about days, and so we do take that into consideration of how a patient's doing and including your perspective as well when helping decide on treatment regimens. So this is the kind of the class that my colleague talked about earlier, the immunotherapy. PD-1 blockade is kind of one of the main classes of immunotherapy, and I thought that this was a little fun cartoon to kind of show you in a more fun approach basically how these drugs work. But basically, cancer cells like to block our immune system from working the way that it should. So if you think about the blue cells, the T cell from our immune system, and the pink cells, the cancer cell trying to attack it. Basically, there's a PD-1 receptor on the T cell that the pink cell or the cancer cell likes to block. And by blocking that, it actually blocks your body's immune response to fighting off those cancer cells. And it can let the cancer cells go rampant and throughout the body. So when we use medications like the PD-1 inhibitors, like pembrolizumab or nivolumab, they actually block this binding of that cancer cell to the T cell. So think of it almost like as a little hard hat on the T cell, so on your immune cell. And that basically prevents that cancer cell from blocking the T cell from working the way that it should. So you can kind of see there at the end, the T cell is actually killing off that cancer cell because it's having that ability to because of that blockade. But although we do ramp up the immune system to fight off the cancer cells, this does kind of release the brakes on the immune system. So there is the chance of toxicities, right? So if we let that immune system go too crazy, it can affect any normal healthy cell as well. So a lot of times I think people have the assumption that, oh, immunotherapy is safe, it doesn't have as many side effects, but we do have to make sure that we're monitoring patients really closely because any healthy cell in the body can potentially be affected. It's important to let other healthcare providers know that you're on these types of medications just because I'll talk about in a couple of slides, but these effects can last for a long time even after stopping immunotherapy. And some of the side effects can be potentially fatal and serious. Although a lot of patients do tolerate therapy very well, it's still important to kind of be aware of these risks. It's important if you're going to a local ER that's not part of a cancer center that you let them know that you're on immunotherapy because they might not be as familiar with triaging these types of side effects. A lot of times it's a diagnosis of exclusion, so we kind of have to rule out other things to see if it is the immunotherapy causing this. And we do use a lot of combined treatment, so we might use immunotherapy with another class of medication, so a lot of times we might have to hold both of your treatments until we figure out which one is causing it. It's definitely important that all patients and caregivers are educated on this, and I'll kind of show a resource that's good to have, like a little wallet card that you can carry in your wallet to say that you're on this type of treatment later on. And this just kind of shows you, so technically, like I mentioned, any organ in the body can be affected by immunotherapy. And obviously it's a super important balance, right? We want that anti-tumor effect, but we don't want to make your normal healthy cells angry. Any organ, like I said, can be affected, but I'll kind of highlight some of the side effects we see more commonly. So including the skin. So think about your skin as one of your biggest organs in your body. Rash tends to be one of the more common things that we see. I'll talk about that in the next couple slides. I'll also talk a little bit about the GI tract and the risk of colitis. So all these itises are kind of the things that we're worrying about because basically immunotherapy can cause that inflammation in the body. The other important thing to point out is that these drugs do stay in the body for a really long time. So as a pharmacist, we always look at half-lives of the drug. So how long does it take that drug to leave your body? Usually it takes anywhere from 4 to 5 half-lives for the majority of a drug to be out of your body. So for example, I have the half-life of nivolumab, which is one of the commonly used immunotherapy drugs. It's 25 days. So if you think about that, even 4 half-lives, that's 100 days before a majority of the drug's out of your body, and you can even see effects long after that. So that's why even when we stop therapy, we still have to be considering this for toxicity purposes. And then, like I mentioned, we'll kind of go through some of the more common side effects that we see. Skin rash, I always tell patients if you're going to pick one side effect of immunotherapy you might get, skin rash is probably the most common thing we see. Up to 30% of patients might get this toxicity. And these are just some kind of common tips and tricks of what to do to help manage that. So in general, I'm always telling patients to make sure you keep your skin well moisturized. Itchiness can also be a side effect of immunotherapy, so if you already have dry skin, that can kind of predispose you to that. I usually recommend any fragrance-free lotion or cream. You want to avoid any like strong perfumes or colognes because that can irritate the skin, even like detergents and things like that. Avoiding tight-fitting clothes because that can also irritate the skin. Making sure to avoid long heat exposure, so that's going to be difficult, especially in Florida, but making sure that you're protecting your skin when you're outside. Definitely either wearing like UV shirts, sunscreen of at least SPF 30. That includes lip too, so making sure that you have like a lip balm that's at least SPF 30. If or at any point you develop any rashes or itching, it's important to let your healthcare provider know because we'll kind of help manage that. And sometimes before even starting this class of medications, your provider might want you to pick up some over-the-counter antihistamine cream or even a steroid cream just to have on hand in case of this does happen. The next toxicity that we'll talk about is gastrointestinal toxicity. And so the big thing that happens with immunotherapy is something called colitis. So think about it as inflammation in your GI tract. And this just shows you we do use combined immunotherapy. So obviously when we're using combined immunotherapy, the rates are going to be a little bit higher with different classes of the medications. And one other important thing to point out is that these toxicities don't happen right away. So it's not like you get your infusion, you go home the next day and you're going to have side effects. Typical timing of onset, specifically for this one, is usually about 6 weeks after treatment. So sometimes when you're coming for your second or third infusion, you might start to develop these toxicities. But like I mentioned before, they can happen way later on. So even 107 weeks into treatment, you could be on treatment for 2 years and all of a sudden have toxicities down the road. Things that you need to report to your provider are basically any changes in bowel habits, especially if you're having abdominal pain, blood or mucus in the stool. And I'll mention diarrhea management a little bit later on when I talk about some of the oral options for kidney cancer. Now, pulmonary toxicity is going to be a little bit less common, but it's one of those like less common but more severe side effects I always like to tell patients about. Basically, there's a higher incidence in lung cancer patients, but we do still see it in kidney cancer. Usually when we have combined therapy, it's a little bit higher of a rate of this, like kind of like with all the other side effects. And this one tends to happen a little bit further out into treatment. So a few months into treatment, you can start to see this one happen. The big thing to watch out for is any shortness of breath or coughing. And this is much different than when you're sick. It's usually like a dry, non-productive cough that patients can get. But it's always better to call your provider if you're not sure. And then usually for this, we'll probably have you go to your closer urgent care if you're far from Moffitt, or come to here. And this is another thing where it's good to have the name of the medication you're on your medication list, so the providers at a local hospital would know that you're on immunotherapy, because they'll triage your side effects a little bit differently. Like I mentioned, it's super important for patients to be aware and be their own advocate as well as their caregivers. So this is a little card that I usually try to hand out to our immunotherapy patients. It's very helpful to kind of have in your pocket just to show any providers at a local hospital with your name, your cancer diagnosis. Usually I'll put what medication you're on and when you're starting it, as well as the main provider that you're seeing and then the hospital's clinic number. And then also just being educated on the side effects that you need to report. So like I mentioned, the shortness of breath is one of the more urgent things that usually I recommend patients go to the ER for. But you can always call our patient care hotline if you are getting treatment, and the nurses will kind of walk you through what to do. And like I mentioned, this can happen even up to a year after finishing treatment. So it's super important even after you finish treatment. So we do adjuvant treatment sometimes, which means we do it after surgery for 1 year. Even after you finish that year of treatment, you might need to report this to healthcare providers for up to a year after that. So now that we've kind of talked about immunotherapy, I know you guys have had your fill of that between me and my colleague today. We'll talk about some of the other classes of medications. Sometimes in the advanced setting, we'll use combinations with immunotherapy and with this class of medications. These are the vascular endothelial growth factor receptors. And I just listed the most common ones we use in clinic, including the axitinib, cabozantinib, lenvatinib, and tivoxantin. But basically think about this. Cancer cells like to recruit your blood vessels to get nutrients, and kind of how this drug works is it kind of cuts off that blood supply. So if you can see over here, if a cancer cell is under vasoconstriction, it actually leads to like the cancer cells dying off, which is what this drug ends up doing. Where when they're in vasodilation, you have normal angiogenesis, so normal growth of the blood vessels. Those cancer cells are able to recruit blood vessels and get nutrients and continue to grow and expand. The downside is when we cause vasoconstriction, we cause some of the side effects of these medications. So things like high blood pressure, like I talked about earlier. We can cause things like hurting the kidneys with proteinuria, hand-foot syndrome where the hands and feet are affected, bleeding or bruising risk. But it's kind of one of those risk versus benefit, just like with the immunotherapy. We have to cause that vasoconstriction to kill off the cancer cells and kind of manage the toxicities as well. So it's definitely that fine balance again. So nausea is one of the side effects we can sometimes see with this medication. And these are just kind of the simpler things that you can do at home to kind of help treat these side effects. It's definitely important, especially if you are getting nauseous, to drink plenty of fluids and staying hydrated. A lot of times trying to drink a lot of fluids at once can kind of be upsetting to the stomach, so usually kind of sipping on small fluids throughout the day. I also usually recommend breaking up meals. So rather than eating like 1 or 2 big meals throughout the day, try and do 5 or 6 little meals or snacks throughout the day. That can kind of help keep the stomach settled. You don't want anything greasy, spicy, or fatty, because obviously that can upset the stomach. And then kind of paying attention to if you are exercising and you're feeling good, making sure not to do it immediately after eating, because obviously that will make you feel sick. And then avoid lying down. I know sometimes our patients can be really tired and fatigued, but you want to try and sit up for at least 2 hours after you're eating, just to help kind of make sure you're digesting everything and you're not getting any of that nausea or like acid reflux. Certain odors can be triggers to patients, so definitely letting like other people in your household know that certain smells bother you, that kind of thing. And then also, if you are experiencing nausea or vomiting, it's important to contact your provider, because there's things we can do to manage it. We can often give you a nausea medication that you can take before this class of medications, and that can kind of help you take it every day, and that way you don't have to deal with the nausea. I always tell patients it's better to stay ahead of the nausea. Don't wait until you actually get sick. If you're having that queasy feeling, definitely reach out to us. And then the other common side effect we see with this class of medication is mouth sores. So a big role that I have with patients is making sure that they're doing all the preventative things. So how can we prevent you from getting these types of mouth sores? Good oral hygiene is really at the basis of this. If you keep your mouth clean and free of bacteria, it's going to make you less likely to have this issue. I also usually recommend using like a baking soda and salt mouth rinse. And I always tell patients it doesn't have to be an exact recipe, like a pinch of baking soda, a pinch of salt, about 8 ounces of like warm water, and gargle and swish and spit with that a couple times a day. It'll also kind of help protect your mouth and prevent this from happening. Super important to avoid any like alcohol containing mouth rinses. So like Listerine and stuff like that can be very astringent to the mouth. There are different saliva substitutes that you can get over the counter, like biotin and things like that, that can also be super helpful. Just because if you tend to have a drier mouth, it'll make you more prone to these type of mouth sores. And sometimes your gums might be more sensitive too when you're brushing your teeth, so you want to be real gentle. Use a soft toothbrush as well. And then if you do actually get mouth sores, it's important to contact us because there are prescriptions we can send in that kind of have numbing agents to help treat these. And especially we want to make sure it's not interfering with your ability to eat or drink. Now we kind of talked about diarrhea a little bit when we talked about colitis earlier. And so this is where it can get tricky with some of the overlapping side effects. Because immunotherapy can cause diarrhea, but so can some of these oral agents. And so a lot of times if you're experiencing these symptoms, we might have to hold both drugs until we figure out which one's causing it. But obviously making sure staying hydrated with plenty of fluid. I usually also recommend adding in some electrolytes like Gatorade or Pedialyte if you are having diarrhea. Once again, the small frequent meals. I usually tell patients to avoid high fiber. I know fiber is usually supposed to be so good for you, but it can be really bloating and cause really upset stomach, especially if you are having diarrhea. So we usually recommend over-the-counter loperamide or Imodium, and we'll kind of walk you through how to take that if you do need to start this class of medications. I also usually recommend anything that can cause gas or bloating, so like broccoli and things like that. And then a lot of patients have, dairy can cause a lot of upset for some patients. So I would say if you are experiencing diarrhea, that's one of the first things to take out. You can kind of go back to that bland diet. I was always taught the brat diet, banana, rice, applesauce, toast, bland, simple things to kind of help keep food digested. And if you are having more than 4 loose stools a day, that's kind of the trigger to call your provider. Just because at that point you might be getting dehydrated, we want to make sure you're optimizing over-the-counter medications appropriately. And if those aren't working, then that's when we might want to have you come into the hospital and get checked out. And then like I mentioned, hand-foot syndrome is another side effect we see with this class of medication. It's basically a rash on the palms of your hands or the soles of your feet. And friction can make this worse. And so you can almost get peeling or callousing of the skin. Sometimes sensitivity, almost like a pins and needles feeling can happen. It's important to stay really well moisturized and kind of exfoliating any dry skin off. There's a couple different creams we usually recommend, but Utterly Smooth Cream is a really great cream that has urea in it, and that can actually help prevent some of that peeling or cracking. But in general, creams are usually better than lotions. They're thicker, they can kind of help keep the hands and feet moisturized. And once again, sticking with that fragrance-free, you don't want any fragrances or irritating things in them. Again, avoiding tight-fitting shoes or socks. You want really loose, comfortable shoes, but you don't want to walk around barefoot either because that can also irritate your skin. So think about wearing socks or slippers around your house and looser-fitting shoes when you're out. Definitely avoiding long, hot showers or hot exposure to the sun. If you are outside, make sure you're wearing sunscreen yet again. And then definitely making sure you're cushioning your hands and feet. So if you're gardening or doing anything like that, I usually recommend you're wearing gloves to help kind of protect your hands. And then if you do actually develop blisters, we usually want to know about them sooner rather than later. Some of these oral drugs can stay in your system for a really long time, so it's always better to call us earlier than wait until they actually get to be open blisters or sores, because then it does take a little while for those side effects to reverse. And then, like I mentioned, this class of drugs does cause that vasoconstriction, so by doing that, it can also increase the risk of bleeding or bruising. So any new or unusual bleeding or bruising is something super important to report. I usually say bleeding that doesn't stop on its own is going to be the emergency. So for example, if you have a nosebleed, you're applying pressure, it's not stopping within 5 minutes, that's something that you probably need to go to the hospital for. Trying to be careful avoiding any cuts or scrapes. One thing to avoid too is if you are shaving and things like that, I usually recommend an electric razor just because it'll help decrease the risk of cutting yourself. The next class of drugs that we use is the mTOR inhibitors. So once again, one of the more common ones that we use is everolimus, but kind of similar to the last class of drugs, it works on the cell growth and proliferation. It basically blocks a certain protein that leads to cell growth and proliferation. So when we block that protein, it prevents that cell growth and proliferation, therefore killing off the cancer cells. This one has a little bit of a different toxicity profile, but some of the things are overlapping. So if we do use it with the former class, sometimes we can see an increased risk of mouth sores, diarrhea. This one also does cause skin rash, much more photosensitivity. One of the more unique side effects with this is the fluid retention, and I'll kind of talk about what to watch out for with that on the next slide. So fluid retention is basically, you want to avoid standing for long periods of time. If you are getting fluid retention, definitely report it to us, especially if it's only on one side, because we have to worry about other things like blood clots. But in general, kind of trying to minimize extra salty foods because that can increase the risk of swelling. Once again, avoiding those tight-fitting clothes and shoes because that can make it worse. And it's a good idea to kind of keep a little weight log. So I always tell patients keep a weight log, a blood pressure log. That way we kind of know when you come into clinic if anything's changing. And if you are gaining more than 5 pounds within a week period, that's something important to report to your healthcare provider. Or obviously if you're developing any symptoms like shortness of breath or anything like that, it's super important to tell us about. And the last class of drugs I'll touch on are the hypoxia-inducible factors. This is a newer class of medications, but belzutifan is the main drug that we have in this class. And basically that hypoxia-inducible factor promotes adaptation to hypoxia. So what that means is the cells can function better with hypoxia. So, which means when they have low oxygen levels. So if we block that transcription factor, once again, it cuts down that cell proliferation, that new growth of blood vessels, and also tumor growth. So they all kind of have the same input, trying to kill off those cancer cells by decreasing proliferation, but they all kind of target different pathways to do that, which is why even though you fail one medication, we do have other options because the other drugs might work even though you've tried one of the other ones. The main side effect we see with this one is fatigue. So I'll kind of talk about how to manage that on the next slide. So it is super important to report any excessive fatigue to your providers, especially with this class of medications. But in general, just fatigue from any of these medications, making sure alternating periods of rest with activity. If you are tired, give yourself a break, take a nap. Regular exercise can actually help sometimes with the oxygenation of the blood, so trying to keep up with walking and things like that if you do have the energy for it. Make sure you're getting enough sleep and that you're not having alcohol or caffeine too close to bedtime. And then if you are having issues, definitely talking to your providers, or if you're having emotional issues too that are leading to the fatigue, stress, depression, we do have social workers available to kind of help with some of these issues and kind of give you resources for that as well. And then kind of knowing when you do feel good throughout the day. So if you know, I always feel good by noontime, like try and plan your activities around that time to kind of optimize your day and make you feel a little bit better. And this is just an overview, kind of showing you the difference. Like I mentioned, the immunotherapy drugs tend to cause all the itises, so all the inflammation in the body, whether it be the skin, the lungs, the colon. We can see all those things with immunotherapy, where with the oral drugs that we use, we tend to see more of like the high blood pressure, the hand-foot syndrome, the mouth sores, more of those different systemic side effects. But like I mentioned, there are overlapping side effects, so a lot of times it's important to report to your healthcare provider so we can figure out if we have to hold both drugs, hold one drug, just depending on what regimen that you're on. And that's all I had for you guys, I guess, if you have any questions.
Fast, so we had to listen quick. Excuse me, I have a question.
Sure.
How long do these drugs stay in your system after you finish taking them?
So with the immunotherapy, like I mentioned, it can be up to a year afterwards. With some of the oral drugs, it really depends on the half-life. For example, Axitinib has a relatively short half-life, so it makes toxicity management a little bit easier because the half-life is basically a few hours. So within a few days, usually we can get the drug out of your system, where some of the other oral drugs, the half-life is like 96 hours, so it can take a few weeks.
So when they leave your system, do the side effects as well leave?
Yes. So usually that's why if you're having the side effect, we'll hold the drug for a period of time, and then the side effects will usually improve, right? And then we can always do dose adjustments. So if you come back and you have a really bad side effect, we held it, the side effect improved, we would do a dose adjustment.
Thank you.
All right, there's a pop quiz on everything you just did. Thank you very much.
No problem.
All right. So next we're going to have Kerry from the Infusion Center come. She'll give you sort of a real-time what it's like to actually go up and get one of these many drugs that Amy mentioned and sort of what that experience like. Obviously it can be very intimidating for essentially any human being to go in there for that first time. So hopefully for those of you who have to go there, this helps shed some light and maybe some tips and pointers for those of you who are already going there. Thank you, Kerry.
Thank you. Hi, everyone. I'm here today to kind of talk about what Amy was just teaching you about. If you're getting some of those medications, you'll most likely be coming to the Infusion Center. We offer different treatments. We have chemotherapy, immunotherapy. You may be coming there just for hydration, maybe some antibiotics, or even blood products. So people come to the Infusion Center for a lot of different reasons. If you're having a lot of side effects, sometimes they send you there. So we just kind of want to tell you what to expect if you do end up coming there as part of your journey. There are a lot of different infusion centers here at Moffitt. You'll see that each one has like an acronym, and it's important to just note the acronym because it'll be on your schedule, and we'd hate for you to go to the wrong infusion center. So just make sure you ask questions if you don't know where it is. But we have the Magnolia campus, which is right where we are right now, and then we have the International Plaza, which is down by the airport, kind of. McKinley campus is just a couple miles from here. Wesley Chapel is right next to like Wiregrass, if you're familiar with the area. It's right behind that. And then South Shore is down kind of more by Riverview. So they're kind of spaced out, and it's, you know, you are allowed to kind of make requests if there's one that works better for you. So just know you do have options. Our goal in the Infusion Center is obviously to work as a team to make sure that you feel supported, cared for, and safe while you're getting your treatments. We have a lot of people that are working in the Infusion Center to try to do that. We always have an advanced practice provider that's working whenever the Infusion Center is open, and they help deal with any acute issues or issues that arise during your treatment. We have pharmacists and pharmacy technicians, and they're working hard to verify your orders, make sure everything matches before we start any treatment. If there's any questions, they're reaching out to your provider and clinic team to address any concerns with labs, any concerns if there's issues that you're having, they might need to adjust a dose, anything like that. So they work hard to make sure that everything is correct before we start anything. Then you'll have the registered nurses, and they're going to be the ones that actually give you your treatment. They'll also give you education and kind of make sure that you're comfortable, treat any issues that you're having during your treatment. Medical assistants might be accessing your port if you have one, doing vital signs, offering you comfort care. We have schedulers at the Infusion Center as well, so if you have issues with your schedule, you can talk to them while you're there, or we also give you the phone number. It's important to get to know the schedulers because we want you to get a schedule that works well for you. We also have volunteers and people in the lobby to ask any questions if you're waiting too long, if you're wondering what the holdup is. They'll work with you to try to get you answers, because unfortunately we do have delays sometimes. So it's important to know that there's a lot of things that will be done before you come to the Infusion Center. First of all, you're more than likely going to have labs. That's going to make sure that you're in the safe parameter to get your treatment. So usually you'll have a lab appointment, then there's a little bit of a delay, and then you'll meet with your provider at the clinic. That way they can see your labs, make sure everything matches up with the protocols for you to get your treatment. You're also going to have to sign an informed consent if you're getting any blood products or chemotherapy or immunotherapy. That's your chance to really talk to your provider, make sure all your questions are answered, you understand what you're receiving. And we can't ever administer a treatment without an informed consent being signed. So there's also options for same-day appointments in the Infusion Center and separate day appointments. We like to point that out to people just because same-day appointments are convenient, especially if you travel far, because you can do everything in one day, but it can also create some delays. So that's just the reality. If you do everything in one day, it's going to be a long day, and there might be some issues in between appointments. Separate day visits are when you do your labs and see your provider one day, and then you come back the next day for your treatment. So you have options, but same-day appointments, if you see your provider and get your treatment the same day, there is at least 90 minutes in between when you see your provider and get your treatment, because the pharmacist has to go through everything. While you're in your clinic, you'll obviously receive education by your provider, but you'll also be taught things by your registered nurse and pharmacist. We want to point out that there is a new patient chemotherapy and immunotherapy handbook, and it really goes over so much information, so you want to make sure you ask for that if you don't receive it. If you don't get it in the clinic, make sure you let us know in the Infusion Center and we'll get you a copy as well. And then just to point out, some people like to have a lot of information before they come to the Infusion Center. Some people like to kind of just wait and see kind of what happens, so it's kind of whatever works for you. But we do want you to know that Moffitt on YouTube has information on PICC lines, ports, on the basics of chemotherapy and immunotherapy. There's lots of resources on there that you can watch to kind of get more knowledge if you prefer to learn more before you arrive. When you actually come to the Infusion Center for your appointment, we want to make sure that you bring your photo ID and insurance card. You'll check in, there's just a desk that they'll check in, make sure everything matches. And then you're just going to have to sit in the waiting room until it's time for your appointment. It's important to note that you have an appointment time, and that's when you actually arrive to the Infusion Center, and then you also have a chair time. So sometimes that causes a little confusion. Your appointment time is when you get there, you get your vitals and everything, and then there's a 30-minute gap where the pharmacist is once again confirming everything, making sure everything's ready, mixing pre-meds. So then that will be your actual chair time. Once everything's ready by the pharmacist, then we will bring you back to your chair. We have, at most of the infusion centers, we have chairs, we have beds. It kind of depends what treatment you're receiving, where you'll be seated, or also just what's available. But if you have a preference, you can always let us know when you check in. If it's your first day getting the treatment, we're going to have the pharmacist in the infusion center come and talk to you. They're just going to kind of assess what you know and kind of where you're at with your treatment, side effects, and they're just going to review whatever you want to make sure that you feel comfortable with the plan. And then the nurse will come in after that and kind of reiterate everything the pharmacist said, and also talk about the pre-medications, the medications, how you're going to receive them, different safety precautions that we'll use. For certain medications, you'll see the nurse wear gloves, gown, different safety gear. And that always kind of intimidates people because they're like, why do you have to wear all that and you're giving this to me? But it's really just because the provider is giving chemo all day, so the nurse just has to protect themselves per the standards. Obviously, we'll also tell you how long you're going to be in the infusion center because that's an important one. Everyone wants to know that. If there's any delays in your treatment due to labs, anything like that, we'll try to keep you informed as well. You're allowed to bring any food, snacks, anything you want while you're in the infusion center. We also have warm blankets. We do offer like a sandwich, each infusion center kind of has a different like lunch. So there are snacks and stuff available. You can also bring whatever you would like to make it a more enjoyable experience. And then there's also internet, pillows, lots of things like that. So just let us know what you need. We do recommend you bring headphones if you're going to be watching the TV and you like it really loud, just for your neighbor's sake. A big concern that most people have when they arrive in the infusion center is they just kind of don't know what to expect. So it's obviously a high anxiety the first day. The good news is most people leave feeling relieved and it went much smoother than they expected. Usually people don't feel any different than when they arrived because you're not going to start having side effects right away. Unfortunately, sometimes you can have like a sensitivity reaction or an adverse reaction to the medication, and that's what we call a reaction. So we just want you to know that that's what we're really trained in the infusion center, is to deal with how to give the medication and also what to do if something goes wrong. So we have protocols that we follow to make sure that everything's given safely. You'll see when you're at the chair side giving your medication, there's going to be 2 staff members, 2 nurses that come and verify your name, the medication dose. There's a lot of checks in place to make sure everything's correct before it's given. And then we're going to have medications that are already ordered as an as-needed basis in case you do have any issues. We can treat them right away. We also have the provider in the infusion center that will come and assess you if you do have a reaction or sensitivity at all. So we'll make sure that you're feeling better. In most cases, if you do react in any way, we turn off the medication, your body kind of calms down on its own. And then sometimes you also need to get other medications just to make sure you fully recover. But it's pretty rare that we can't restart the medication and finish it. Let's see, the other thing is if you do have a reaction, we always communicate with your clinic team and your provider. We let them know what happened. Sometimes they make adjustments for your next treatment, adding more pre-medications, maybe slowing it down, whatever they have to do to try to prevent it from happening again. Some other helpful hints, just for when you come to the infusion center. It's important to know, we always recommend, especially the first time, that you bring someone with you if you're able to. Just usually people are really nervous in case you have a reaction and you get medications that kind of impair you to drive. A popular one is Benadryl that we give if you have a reaction. People think, oh, that doesn't affect me, I take it. But when it's IV form, it kind of affects people differently. So it can make you really sleepy. But if you know you're getting a medication that's going to sedate you, then we require you to have a driver. So just kind of communicate with us if you have any concerns about that, because we can also help figure out a plan so you have a safe way home. Also, if you take pain medication on a regular basis, we ask that you bring it with you, because if you don't have it with you, it can delay your care. And we want you to stay, comfortable while you're there. So it's okay to take your pain medication as prescribed, and you can just let your nurse know, like, oh, I'm going to take my pain medicine. Just kind of keep us informed so we know if you took something. If for some reason you're not feeling well before you come to the infusion center, let's say even you've been getting your treatment for a month, but you're really not feeling well, we ask that you reach out to the clinic before you come, because that's going to help prevent you from being delayed in your treatment as well. Sometimes if you're not feeling well, they're going to want to run more tests. They might postpone your treatment. So it's important to just communicate with your clinic team. Your provider will kind of tell you probably the best way, whether it's to call the triage line, call the nurse, use the portal. So you might want to ask at your clinic appointment what's the best way to communicate with your team. We encourage people to bring their visitor with them, but we also just want you to know the space is a little confined at most of the infusion centers, so we only allow one visitor back at a time. But if you do bring your whole cheering squad, that's fine, but you can just have one back at a time, so you'll have to rotate just due to space issues, and so there's enough space for all the staff. The visitors that you bring also have to be at least 12 years of age. Sometimes people run into issues with children and stuff, so we just want you to know that they're not allowed back in the infusion center unless they're at least 12 years old. Again, just as a reminder, they really want to stress the patient education aspect. So make sure that any side effects you're having, you communicate with your team, because sometimes they will modify your treatment a little bit if it's getting too severe, or there's other medications they can give you to help with your side effects. But if you have any questions at any time during your journey in the infusion center or here at Moffitt, just make sure you reach out to a team member or ask somebody in the infusion center, and we'll make sure that we can try to connect you with the right resource. That's all I have for you guys. Do you guys have any questions right now? No? All right, well, take care.
All right, thank you so much, Kerry. All right, for the next part, we're going to actually have a patient panel up here, so I'll invite the patient that are so courageous and brave to come up here and share their stories. And really, this is just a chance for them to speak on what's important for them. Obviously, all of these patients have a kidney cancer story, and they differ, I think, in important ways. And those two stories are the same, so even patients who get the same drugs, have the same surgery, can have very different experiences for very different reasons. So appreciate that. So, and then I'll have Amy, who's going to come up here and sort of run the show, because she can probably answer more questions than I can. So I'll have Amy take over. Then if Peter, Mr. Hopkins, Caesar, I don't know if Caesar yet.
My name is Peter Cruz. Used to live in Lakeland. I've had cancer twice. My first renal cancer was 35 years ago, roughly. Absolutely no serology, no symptoms, anything. I'd given blood and was told I had hepatitis. Well, we did the research and we found out that Tylenol, wild turkey, caused different effects. So my particular cancer showed up as a false positive with no serology. That particular operation went into the hospital, in and out in 3 days, less than 3 24-hour days. They cut 2 ribs out. As my doctor in Auburn, Alabama said, that's ancient history compared to what they do today, when I told them 5 years ago I'd done it. When I came here, you have to understand the most important thing is to be positive in your attitude. None of this why me, be positive, because everybody else that's here is suffering the same condition. When you come here, you're part of a family. And I can't stress that enough. Is back for our, roughly, this is the 5th year, but in February we came back, and I'm walking down the hall, and one of the guy comes by and says, "Hello, Peter, how you doing?" And he was a doctor I'd seen years ago. But you're part of a family here. Now, Dr. Manley was my doctor here. was following up a hernia surgery, and in Lakeland, and the nurse, Crystal, called me and said, "Doctor wants to see your urologist. They're 4 months out. He wants you to see one now." She said, "I'll call you right back." Called me right back. She said, "You got an appointment tomorrow at 10:15. So we came over here and we went through all of the different stuff, the procedures. Now, one of the most important things, in my opinion, and I'm sure it's yours, is the person that comes with you. Because a lot of the times you'll be asleep and they're sitting out there waiting for you. And long surgeries are very important, and also bring a jacket because it's colder than you know what over there. But Dr. Manley came in on his research day on a Friday and spoke with my wife and I, and he gave us 4 options. He said the first thing you can do is nothing. The second thing you can do is we can try an ablation. You might hear the word ablation. Ablation is where they put medicine in you to stop the growth. He said if that doesn't work, then we have to do another procedure. This option for that procedure is going to be autologous kidney transplant, which is where they take the kidney out. Dr. Manley takes it out. He takes it over here on the table, and he does his work on it. He goes over, it's a Tampa General, and he hands it to the other transplant team that puts that in. And the 4th option that we had, which is what we chose, was to do everything in-house here. And it was a long process, successful. Wake up, all the people, I was here for 10 days, up on the 5th floor of the surgery, and by the grace of God, I'm here today. Thank you.
Okay, great. Good morning. My name is David Hopkins, and I was diagnosed with renal cell carcinoma, stage 4, back in early 22. So, but I'm still here. So, I mean, it's working anyway. It's been a long road to hoe, and I'll tell you, I never realized how many people battle with cancer until I came to Moffitt, and it just floored me totally, because when you're not involved with cancer, you really don't quite realize just how prominent it is and how devastating it is. And throughout my journey, my wife has been my rock, Laurie. I mean, that girl hasn't missed an appointment with me, and she deserves my hands up. Anyway, so what happened is I had a backache, and this leads me to one important aspect of all this, but I had a backache, and I've been to the doctor, been to my primary and everything. At that time, I was living in Kentucky, and I had a little backwoods medical place, but anyway, he told me, "Dave, you're getting old, He said, you've just got arthritis in there, and blah, blah, blah." And that happened a couple of times, and then shortly thereafter, me and my wife moved back to Florida, because that's where we originally had came. We actually spent some time up there in the high hills of Kentucky. So when I came back and had to pick a new primary, is when I said to my wife, I said, "That's it, I'm gonna find out what the heck is going on with my back, because it's more than arthritis." Needless to say, my primary went along with it and sent me to the first the X-rays, and then the MRIs, and finally the bone scan. And I'll never forget that, because the doc brought me in to show me the bone scan results, and he said, "Well, if you see anything light up on here, this is where you have cancer." That damn thing looked like a Christmas tree. I mean, it wasn't good, So anyway, it kind of really scared me pretty much, and I thought, well, I got to put things in order now, because this could be it. In any case, time went on, and treatment. The doc doctor out of Moffitt here in Wesley Chapel, actually. And he hit it hard. He hit it with everything they had. They put me on immunotherapy, they put me on chemotherapy, and everything that they had to do this. And it hit me pretty hard, you know. When I was involved in that for quite some time, I was receiving that Pembro, you know, and some chemotherapy at the same time, some Adjuvant. And that went on for quite some time, and it really made me quite sick for a while. You know, I lost a lot of weight and all that kind of stuff. My appetite just kind of went by the wayside. And but the longer I took the immunotherapy and the chemotherapy, the better I started to get, slow but sure. You know, and that went on for better than 2 years. I had 35 treatments of Pembro and Adjuvant, and also a bone builder because it had spread to my bones. You know, I back up just a little because to let you know, when I was officially diagnosed with cancer, they told me I have cancer in my kidneys and in my liver and in my pelvis and in my ribs. And anyway, it was kind of everywhere, you know, so it wasn't looking real good for me, but I managed and I got through all this stuff, and you know, and I feel better today than I have in years. So, you know, there's hope. You know, it's not a deadly, well, it may be eventually, but it's not a deadly diagnosis. You know, my very first doctor that admitted me into Moffitt said, Dave, she said, you have a cancer and it's incurable. However, it's highly treatable. So what do you want me to do? Do you want to get treated? And I had people that I showed my results of that bone scan to, who was a former radiologist. And she basically told my wife, she said, Laurie, this is not good. You know, you know, take him home, make him comfortable, put things in order, get ready. Because, you know, well, that's not the case anymore, people. I'm here to tell you. Treatment is there, it's available, and it works. And it works. And so to this day, I put on a little more weight now. It's, you know, I try all the time, but I guess I never was real big anyway. So, but in any case, you know, my docs and everything, and the whole treatment team, I was never treated with such totality. It was unbelievable because they assigned me a whole team. I mean, everybody from a pain doctor to a blood doctor to, you know, I mean, the list went on and on. I mean, I couldn't barely keep up with all the names. Anyway, the end result is I'm still here. There's hope for cancer patients out there, even though it may have spread to other areas of your body or throughout your body. You know, it's not the end. People, you know, have faith, and I hope that those new people that may have the opportunity to see this realize that they're not the only ones, and then they won't ever be the only ones until we find a cure. But we're getting close, people, and you know, I'm all for it. So go Moffitt. Thank you.
I think that's a good point that you brought up, is just being your own advocate. So I always stress that with patients enough, is that we have a lot of patients that come here from second opinions from smaller institutions that might not get the right opinion. So you always have Moffitt there. We hear with the experts that can get you the best data, the best information. But like you said, there is a hope too. I think a lot of people come in with stage 4 disease.
Yeah.
It's a great example that we can possibly, so are you on a treatment break right now?
You know, it's also very good to know that, know your own body. Right. There's so much that, I mean, your body tells you stuff the doctor's not telling you because they don't know, they don't feel it like you do, you know? And that's the biggest thing I can take away from this, is that listen to your own body because it'll tell you if something's really wrong and what needs to be done and that kind of thing. So, thank you.
I'm with Simon and Garfunkel because silence is golden.
You got it, that's right.
We want to hear from our patients. So if you're having side effects, do not hesitate to reach out to your team. You have a whole team, including me, the nurses, the doctor, that'll work on all the side effects and everything. So.
Oh, and incidentally, during that journey, I was having a period of time where it was very hard for me to get up out of a chair, to stand up. You know, well, today, I'm standing way better because they put me, my team of doctors put me through radiation for 2 weeks. Pinpoint radiation. I remember the doc when he first was telling me this, he said, it's not like it used to be. This is pinpoint. It's almost like spot welding. I thought, okay, I can relate to that. Anyway, it worked. 2 weeks treatment, once every day. It didn't take long. I went in and got the treatment and everything, and 2 weeks later, and still today, I don't have any problem getting up anymore. You know, so there's a lot of things that can be done out there and treated and to make you better and to make you feel better. So don't give up hope.
Exactly. You guys have any other pieces of advice for the crowd, or anything else that you went through your journey that you felt was difficult? Or?
Well, you just have to be positive. In here for 10 days after the surgery, partially wake up, I'll put it that way. And I got 2 garden hoses coming out my neck here. And those were for dialysis. So received a couple treatments of dialysis here, and then went for the full course. And luckily, my wife calls it LK, little kidney. LK started back up, so I can function. I can play golf. I can still play golf. I don't play as much as I can. I'd rather fly fish. But I can outdrive most of the guys 50 years old. And I'm just 78.
Yeah. Oh, and I forgot to mention my doctor, his name is Chada, out of Wesley Chapel. The man is amazing. So he's got a great team. So just so that everyone knows that.
Yeah, he's part of our GU clinic. He rotates here too, so we get a 1-day week.
There you go.
But we do have providers at all the campuses, and we all work together. So even if you're being seen at one of the community places, so like at MIP or McKinley, they also communicate with us. So in GU, we see GU all day. They might see multiple tumor types, but they have us there as a reference. So it's important to know, no matter where you're going with the Moffitt family, they still have the resources of the GU clinic.
And they made a family.
Yeah.
Yes, exactly. Go ahead, you have a question?
Not really a question.
Sure.
My husband's not on the panel, but I wanted to see if I could share his
Yeah, sure.
story as well.
Do you want to come up here? You're like, no. Come on up.
I'm only doing it because I'm too shy. I don't want to.
Okay. I think it's a small enough room. You talk loud enough like I do. That's good. Well, you don't have to. You never know what you can.
Okay, so my name is Kim. My husband is Neil. In 2022, Neil thought that he had a hernia. So, and he had had one before, so he had the flank pain and went to his general doctor, and the doctor said, well, I'm 99% sure it's a hernia, but I'm going to send you to a urologist and just have him do some tests and double check. Neil went to a urologist. They did some testing. They called us, the urologist called Neil specifically one night. It was like 8:30 at night. So that was a little concerning. And he said, sorry, I'm a little nervous. It's kind of hard to talk about. But he said, I've found something on the scan. There is a 12 to 14 centimeter tumor on your right kidney. And it doesn't look good. It looks like it could be cancer. So obviously everything changed that moment. And we had a choice of going to Shands in Gainesville or coming here. We tried Shands, and there's a lot of paperwork, and so I just started praying, and I was like, okay, what do I do? So I decided this is where I wanted to go. My sister-in-law had studied here, did research, So I called and we were led to Dr. Manley. Our very first visit with him was overwhelming because, again, like they were saying, you don't know until you hear that word cancer and you hear the stages. I'm thinking, okay, we're just gonna, Neil's first response was, well, we'll just remove the kidney and I'll be okay. And that's what we thought. But they look at Neil's scans and he said, we think it's intertwined with the renal vein. So it's not that easy. And it's very large. It's so large that we can't remove the kidney right now. So he had to do his Enlita and Keytruda first. So he did that first. She went over, she was great, went over all the side effects, everything, and for the first month or so, Neil did great. You know, every 3 weeks we went. Neil has such a sense of humor that we go online and he finds shirts that says, and excuse me, but first thing he did was a kidney cancer shirt that says, I have kidney cancer now, I had to open this, and it's cannibal bass. And that's Neil. That's like, I'm not gonna give up, I'm gonna fight. And everybody at Moffitt has just been wonderful. I mean, I swear that we were led here and led to Dr. Manley. Fast forward a few months, Neil experienced his first side effect, other than the minuscule ones that you see on the screen. His thyroid quit working, no problem. He's on levothyroxine. He was grumpy for a while though. And cold, always cold, freezing. And even ketchup, he loves spicy food, but even ketchup was spicy for him. Very weird. And then fast forward to Father's Day. This was bad. So Neil was like not feeling well that day and just like a stomach virus. And I remember saying to him, because he kept vomiting, but then he'd act normal. And I said, you know, if you're still not feeling well tomorrow, we're gonna bring you to the doctor. Something just doesn't seem right. And he was like, okay. Well, in the middle of the night, he wakes me up and he's like, Kim, I can't breathe. Something's wrong, you need to call the ambulance. So I call the ambulance and they get there and they just start checking him out and they're like, are you a diabetic? And he said, no. And they said, well, you are now. And I was like, well, what are you talking about? And they said, your sugar it was like 600 and something. Wow. I'm like, I honestly didn't know what that meant. Obviously, I could see how Neil was acting, so I knew it was bad. And they took him to the hospital. The doctors there were like trying to tell him he has cancer, it's stage 4, this is the medicine he's taken. This is a very rare side effect, but we believe that this is what's happened because he's not diabetic. Well, by the time he got there, his sugar was 850. And they couldn't get an IV. It was just a very traumatic night. From that night on, Neil became a diabetic. And Neil is still a diabetic. After all that, he was in the ICU for a few days. We got the sugar down, and then it was a whole change of life because we had to figure out how to give him insulin. If you could have seen us all, my son, me, and him sitting at the table when we got home trying to do the vials of insulin, figuring out how to do it and how our life was going to change. Well, fast forward, we came to see Dr. Manley, and Dr. Manley said, that's it, we have to stop. We have to stop all the medicine. We're gonna have to do surgery now. And we were so scared because I'm thinking, did it shrink enough? Did everything work enough? This is so amazing. On August 11th of 23, Dr. Manley did the surgery. Neil's family flew from Arizona here. We prayed, we prayed, we prayed. Dr. Manley, before the surgery, said, I just want you to know I'm going for a cure. Now, we knew it was supposed to be intertwined with the renal vein and that it was going to be tricky. After many hours, Dr. Manley found me. I wasn't even in the waiting room. I was downstairs with my in-laws, like at this little cafe, and I was so scared because it had been past the time when they were supposed to give me an update, and he went and specifically found me. And when I saw him, he's like, we're done. We got it all. And I was like, looking at him, and he brings me in a room, and he said, the tumor was dead. And I'm like, dead. Totally necrotic. The tumor had, the 12 to 14-inch tumor was now, it had shrunk and it was dead. Neil is now just 2 years cancer-free.
Wow.
And he still wears his smart ass shirt. He still has cancer-free, kidney not included. I mean, that's just him. But we are so proud of him. We are so thankful for him. We know that it does work. Yes, he's going to be a diabetic the rest of his life. Would I trade it for anything? Absolutely not. We figured out the pens way better than the vials. I will tell you that it's a very rare possibility, and what's different about it is it's a type 2 that acts like a type 1. Meaning, my mom's a type 2. I can see stuff she eats, Neil can't do it. Neil is on his constantly, but he's here, and he's very healthy.
Thank you so much for sharing that story.
All right, so we are going to break for lunch. I hope that, first I want to thank all of you, especially Mrs. Asher and Neil. We didn't plan to have your story, but that was an amazing story. And I hope during this next hour, all of you guys can, feel free. I'm sure they're happy to ask questions for many of you going through similar things. But the rest of you, just get some lunch. There's one quick announcement we have from our TCC. You're going to hear from Patel later. She's one of the people that have organized this, that I mentioned in the morning, but she's been busy outside. So I'll let her just give one announcement, and we can all go eat.
Hi everyone. We have a table outside recruiting patients and non-patient participants. Everyone that's interested in helping in research in any way, you can go by and we can ask all the questions that you have. If you are a non-patient participant, we may attempt to get blood from you today and collect a survey. And yeah, hope to see you around.
Thank you, everyone.
So the next talk is going to be from kind of our dietitian services. I think it's great to kind of have some guidance. We get asked a lot of questions from patients. What should I eat? What I can't eat? So I'm going to have Diane come up. And I'm going to let her take it from here, especially perfect right after eating lunch. So here we go.
Good afternoon. I've really enjoyed the conference so far. I hope everyone else has too. I know I'm learning a lot. So my name's Diane Riccardi, and I'm one of the dietitians at Moffitt Cancer Center. I've been here for 25 years, so I've seen quite a few buildings go up, including the one that we're in right now. And as you know, we're trying to expand out and get closer to you all so you don't have to make such a long drive to get your treatments. It's my pleasure to talk to everyone today, and the questions that I've heard so far are just, I've just been amazed at how educated our patients have become about their disease and looking for clinical trials, and we do the same thing with nutrition. We're always looking to expand and see what we can do better. So today I'm going to talk about how nutrition plays a role in your kidney cancer treatment. So a dietitian can be very helpful across the cancer care continuum. And of course, Moffitt has a very strong prevention program too, but we're going to today focus more on how the dietitian works and along with the team in helping patients through their treatment, Mostly what we're doing is we're helping patients stay nourished and manage their side effects by changing diet, making some dietary changes. But the dietitian is also vital in survivorship roles. So for early stages of kidney cancer, for people who've had a nephrectomy or have one solitary kidney, the question is always, how do I keep that kidney healthy, especially if I have high blood pressure or diabetes, etc. And dietitians can be very helpful in that setting also. So let's kind of start with nutrition support during treatment, because many of you are still on some treatments if you have advanced stage cancers. So the most important thing is staying nourished through your treatment. So we know that as you're nourished, that it really allows you to better tolerate your treatments, right? If you get very undernourished or if you get very dehydrated, your treatments might get delayed or put on hold. They might be changed if there are just too many side effects that we're not able to manage because it's really interfering with your quality of life. Ideally, you are not going to change your diet too much when you're first diagnosed with kidney cancer. Many people do that because they go online and they start reading about renal diets and other types of things. So they start coming in already changing their diet. But we really want you to limit your diet restrictions in the beginning, because restricting your diet can restrict your nutrition. And you may not be getting all the nutrients you need, which you're going to need to go through treatment. So, for example, if you eat a diet that's too low in carbohydrates, you can start breaking down muscle to be used for calories. So that's very important that you're getting adequate calories. And sometimes we have to focus on that because people will come in and say, well, you know, the average American is overweight. So of course people will come in and say, well, I can lose a few pounds. That won't be a problem. And I'll say, well, let me tell you a little bit about if you lose your lean muscle, especially if you're losing weight quickly, that can interfere with your immune system, and it will also interfere with your response to therapy. So it's very important that you stay nourished during your treatment. The other thing dietitians do is they help manage side effects from some of these treatments, and you hear about the side effects, you're experiencing those side effects. And the nurses are wonderful and they're here to help you, and you've already heard some nutrition suggestions on how to manage those side effects today. So I always say that the dietitian's job is to help manage the side effects, but still help you really enjoy what it is you're eating. So these are just a few of the side effects. Now, if you're a Moffitt patient, you have access to a dietitian. All you need to do is speak to your team and ask them to make a referral to you for a dietitian. We do consults in telemedicine, we do consults in person. So whatever is most convenient for you. As far as your side effects are concerned, if you're having nausea, you're going to start making some changes to your diet. But if you're finding that those changes really aren't improving your intake and you're losing weight, you may have a referral to a dietitian who can make some suggestions for you. So for example, you may know, well, I'm supposed to eat small frequent meals, but I'm too tired to cook 5 meals a day. The dietitian comes in and says, you only have to cook 3 meals a day. Just eat half at a time. So sometimes those little suggestions can really help improve your intake. Diarrhea is another side effect. And what I want to kind of focus on here is every time someone has diarrhea, it's very hard to stay hydrated. They get dehydrated, they get nauseous. So you can get other types of side effects and they kind of build. And it makes the treatment really, really difficult for you. So every time you have a loose stool, I always tell people, take a drink of water after that. Like right away, kind of a water chaser, just to help stay hydrated. The other thing is there are 2 types of fibers. So you hear, well, a low fiber diet. There are soluble fibers and there are insoluble fibers. So soluble fibers are like bananas, applesauce, some of the things you saw on the slide earlier. Those are soluble. They're like little sponges. So when they get in your gut, they help absorb water. So they can reduce diarrhea that way. The insoluble fibers are things like the skins on fruit or the skin on a baked potato or the stem on a broccoli. Those go through like Brillo pads. So if you're having diarrhea, those are going to go through pretty quickly and you're going to get some gas and bloating from that. Obviously, smaller portions people do better with. Taste changes is a big thing. When I have someone comes in and they say they have no appetite, I'll get a consult, poor appetite. And I find out, it takes a little detective work, but you find out the reason why I don't have an appetite is because nothing tastes good. And you know, if you've raised children, that if you try to get a child or a baby to eat something that doesn't taste good, they're not going to be eating. So it's the same thing if you're experiencing taste changes, and if you're leaving out some major food groups, there are a lot of little tricks that we can do. So not only using herbs, but moist foods taste different than dry foods. Cold foods taste different than hot foods. So what I usually do is I usually say to someone, what does taste good? And we start with that. So if they say fresh fruit, then I say, great. Let's have some chicken salad like Alessi did here, and let's put some grapes and mandarin oranges in it. Then that chicken salad's really going to taste good, and you're going to be able to get down protein. Now, if you don't have access to a dietitian, there are a couple handouts that are outside, and one of them you see here, the eating hints. So that does go through different side effects and different types of, changes that you can make in your diet. So that's very helpful. Okay. Now let's talk about a little bit more about survivorship. Say you're managing your side effects well, but of course you want to know, how do I keep this kidney healthy? Okay, so all these things are important for kidney health. So controlling your blood pressure is very important. Managing your blood sugars, avoiding smoking, maintaining a healthy weight, and staying physically active. So dietitians can really help in all of these things. So, for example, managing blood sugars. If your blood sugars are high, that makes your vessels sticky. And if your vessels are sticky, then the vessels that go through the very vascular kidney are also getting sticky, and they can become occluded. And it can be harder for your kidney to do its job of filtering. So getting blood sugars under control are really important. Blood pressure, if your blood pressure is high, then that can cause hyperfiltration. That can make your kidney work too hard. And we really want to get that blood pressure under control. Smoking, the same thing, it can affect the vessels. Maintaining a healthy weight, so as you probably know that being overweight is a risk factor you saw for kidney cancer. So it's important to maintain a healthy weight. So trying to lose some body fat, but still not be too lean, so not be underweight, but trying to lose some additional body fat is going to make it easier for your kidney to work. And of course, physical activity. Okay, so you're hearing about how important the kidney is, and that it regulates, it's mainly your main filtration organ. So if the kidney is playing this crucial role in filtering, what's it filtering? So these are some of the things that it's filtering. And as you can imagine, we're basically getting these things from our diet. So our bodies can't make potassium. We have to get it from our diet. So vitamin D, we get from the sun, but the kidney converts it to its active form. So the kidney is very important in kind of regulating all these things. Protein, the metabolites of protein are regulated by the kidney. Sodium and potassium are your electrolytes. Phosphorus and calcium are your minerals. So these are just a few of the things that the kidney is very important in regulating and that we get from our diet. So how to support your kidney? Basically, stay well hydrated. So the main thing would be, for most people, even if they have some kidney dysfunction, if it's a very mild kidney dysfunction, staying hydrated, getting enough liquids is very important. Only if your doctor said that you need to restrict your fluids, should you be restricting your fluids. Otherwise, you should be keeping those kidneys nice and flushed, because if their job is to filter, they need water to be able to do it. Limiting salt in the diet is another way of kind of helping the kidneys work a little bit easier. And that's not easy to do in America, because in America, the code for seasoned is salt, which it isn't in some European countries. Eating more plant-based diet, we're going to talk a little bit more about that, but it looks like the evidence is saying that plant-based proteins are easier on the kidney than animal-based proteins. So if we're getting our proteins from nuts and seeds and beans, that's easier for the kidney to metabolize than if we're getting it from meats. And then limiting ultra-processed foods, and I'm going to show you some evidence showing that can contribute to kidney disease. So what is enough fluids? So the dietitians and doctors will do some calculations using your weight in kilograms, but the easiest thing I think for you to do is to take your weight. So say you weigh 140 pounds and you divide it by 2, so you would need 70 ounces a day. And that's usually going to be a little more than 2 liters. So kind of that rule of thumb, like 8 cups a day, doesn't really apply to everyone, but it's a starting point. Men actually need a little bit more water than women, and that's because men have more muscle than women do. So men just naturally have more muscle, and where there's muscle, there's water, so they need more water than we do. But you can also get fluids from water-rich foods. So, and I'll show you some examples, but water-rich foods can provide up to 2 cups of fluid a day for us. Okay, how to stay hydrated. So this is where I say where the dietitian comes in. You know what you need to do, right? How do you do it? So here's the dietitian trying to make things easier for you. So what some people will do is they will front load their hydration. So what you do, you start off in the morning, right, with the best intentions. I'm going to get this done. I'm going to eat healthy today. So sometimes kind of getting up and getting that 12 or 16 ounce, if it's a water bottle in, and you can kind of front load. Set a sip strategy. Say you feel nauseous from your treatment, and drinking a glass of water is just not going to do it. You're going to want to kind of sip on something throughout the day. And they have these really fun water bottles that if you don't pick them up like every 15 or 20 minutes, they start lighting up. And we have some of our admins have them on their desk, and you'll see it lighting. It's like you're supposed to be drinking, Some people have their watches tell them, their smart apps, they're all kinds of things. We talked about water-rich foods. These are some examples of water-rich foods. How do you know if you have a water-rich food? Well, if you take a bite into it and it's dripping down your arm, you definitely have a water-rich food. We were just in Seattle, and I said, "What's sweet today?" He said, "A nectarine," and I needed like 4 napkins to be able to eat it and get around. Infuse it or cool it, that means get fancy and make spa water. So you can put some fruit in it and make it a little bit fancy, because people get tired of drinking just water. And then kind of watching for signs of dehydration. So, and I'm sure your doctor goes over these things with you, but when you go to the bathroom, your urine should be kind of a straw colored. Maybe in the morning it's dark, because hopefully you've slept most of the night without having to go to the bathroom. But throughout the course of the day, the urine should be getting lighter and be more of a straw colored, so that you're hydrated. Okay, what to drink? Okay, so obviously mostly water. That's what we're giving you mostly today. Fruit juice is an option. People are concerned sometimes about the sugar. So if you have diabetes, a lot of times your dietitian's like, "Oh, I'd rather you have an orange than orange juice." That's for a low blood sugar. So what you can do with fruit juice is you can kind of put a splash, if you wanted to, in your water, just to kind of give it a little bit of flavor. You can put fruit in it. There are unsweetened sparkling waters, and you could do like more decaf or caffeine-free types of teas or sodas or coffees. Limiting sweetened beverages, energy drinks. Electrolyte drinks are good if you're having diarrhea, but if you're not, you may not need that extra sodium and potassium that's in there. Alcohol also can be dehydrating to a certain degree. Caffeine drinks, if you're drinking more than 2 cups a day. So these are just kind of some examples of kind of what some of the best things to drink are. There are some studies that very interesting studies. They were cohort studies, so they were large groups of people, and it showed that consuming sugar-sweetened beverages or artificially sweetened beverages can really contribute to chronic kidney disease. So artificially sweetened beverages aren't necessarily a replacement for. So if you're doing Pepsi, automatically going to a Diet Pepsi may not be the option that you want to switch to. Okay, choosing mostly plant proteins. So how do you do this basically? You want to try things like whole grains and beans and legumes and nut seeds. These types of things are all kind of plant proteins. There are meat alternatives. They're pretty popular that are out there. You just want to check the salt content, because they are highly processed. So some of them can be very high in sodium. And if you're trying to watch your sodium intake, you might find that Impossible meat has a lot more sodium than your hamburger would have. So this is just a way of making it easier for your kidney to digest the foods that you're providing. This is an example of a protein flip and what we could do. So this is just a classic chicken marsala, where you'll have the chicken breast, and then you'll have your pasta, and you might have some mushrooms or something in there. So by doing a protein flip, we're basically doing more mushrooms and less chicken. And then here we actually took the pasta and we changed it into quinoa to try to give you a little bit more of a whole grain. And then we added some color by putting some spinach in there. So it looks just as delicious, but it doesn't have as much animal protein. And that's why we call these protein flips. Okay, another really simple way to eat more plants is to put more plants on your plate. So the typical American diet, usually when you go out to order your meal, you start with your entree. So you decide, am I having chicken, fish, beef, etc. And then they say, and what sides would you like? So they're implying that the main source is going to be on half the plate. That's going to be the star of the plate. So all we're suggesting is that if we make half the plate your fruits or vegetables, so if you order double vegetables, and then your protein and your starch are 1/4 each. So now you're looking at a plate that definitely has more plants, but it's still a plate that's full, and it's still a plate that's colorful, and it's still a plate that's delicious. So how do you do this? You basically go slow. So we start with, I grew up definitely with things like, a steak and peas and mashed potatoes, and then you kind of move it a little bit more slowly. So we took the peas out because they were a little starchy. We put some green beans in. You saw that steak got a little bit smaller. And now we said, I'm really going to get excited here, and I'm going to put some reds in there and some yellows in there. So you can see I can make an absolutely delicious plate that's really mostly plants. Okay. Salt. So the average as you can imagine, the average American diet is too high in salt. There is salt in a lot of foods. It's hidden in a lot of foods. It's in a lot of processed foods. So the recommendation for everyone is 1,500 to 2,400 milligrams a day. But there are a lot of claims on food labels. So sometimes when you're looking at food labels, it's a bit confusing. I will often have to turn the package around so I can find this nutrition facts label. So if you've ever gone to the grocery store and you've seen the food packages like turned around, then you know a dietitian has been there. So the dietitian really feels like that nutrition facts label should be on the front, and don't believe anything else that you read. So when you look at your nutrition facts list, so you can look at all these things, sodium free, very low sodium, low sodium. Sometimes they never had sodium and they say it. So you can see all those things on the front, and you can memorize what all those things need. Or you can do what the dietitian does, and you can just turn that package around, look at the nutrition facts label. There's always sodium listed on the label. It's been there forever. And if you look over at the percent daily value, if you're looking at something that's 20% or more, that's going to be a high salt item. If you're looking at something that's 5%, this particular item 7%, that's going to be something that's lower in sodium, a little bit healthier for your kidney. The most important thing is to look at the serving size, because the bags of chips and things that we give out, those aren't always one serving. So if you're eating the entire bag might be 2 servings, so you would kind of have to double that sodium value in there. So important to look at the nutrition facts label and the serving size. Okay, so here's a little practical tip. So this is a homemade soup that we made we were doing a survivorship group with breast cancer patients, and we were doing a teaching kitchen. So we were in our kitchens, they were in our kitchens, all of us were on Zoom, we were all making the same recipe. So this is a colorful lentil soup that we were making. If you make homemade soups, obviously they're much lower in sodium and they're delicious. So learning to cook at home, it's really very interesting how many of us don't. Limiting ultra-processed foods, because that's really a way where you're going to get a lot of salt and added ingredients. Reading the food labels, we talked about that. Some people will say shop the perimeter of the store, right? Because the processed foods are on the inside, but so are the herbs. So I don't completely do that, but you can try doing that. Using things in place of salt, there are a lot of examples. Kind of unsalt your snacks. So if you're having snacks, you're looking for kind of low sodium things. And then be cautious about salt substitutes. If your doctor said your potassium is a little bit high, you want to be careful of something called a salt substitute. So I had someone using salt substitute because they knew they needed to eat less salt. And the substitute, instead of sodium chloride, it was potassium chloride. So it was a very high dose of potassium that they didn't realize that they were getting just from that salt substitute, because they were kind of looking for that bite. And you can get that same kind of salt bite if you use like vinegar or lemon juice. Sometimes you can still get, or some sort of spicy pepper, but you're looking for flavor, and salt does give foods flavor. So you're gonna have to be creative about finding things that taste good. Here's your ultra-processed foods. So I grew up on both these foods. So you know both these crackers are sold in this, they're right next to each other in the grocery store. They both come low sodium. So the Ritz cracker, Ritz is called like a hint or something. It's got a little bit of a different name for their low sodium. And the Triscuit also comes low sodium. So okay, you're like, okay, this is great. Both these products are low in salt. These are low salt crackers. If you look down at the ingredient list for the Triscuit, so the Triscuit has 3 ingredients in it: whole grains, canola oil, and sea salt. So those are 3 ingredients. If you look at the ingredients in the Ritz crackers, there's a lot more. So you can see the Ritz crackers, which are sold on the same shelf as the Triscuits and are bought almost as often, are a lot more processed and have a lot more, are ultra processed. And what we know is that people who consume high ultra processed foods had a 24% higher chance of developing kidney disease. So very important to try to bring down the processing. There's an app which is super fun. It's called Yuka. Y-U-K-A. It's a free app, and you can scan the barcode on the product and it will tell you how much processing, and you can also use it for things like cosmetics and other things if you want to see what's in your products that you're putting on your face. Now we're just going to end with 2 very common questions that we get. Do I need to be on a renal diet? So there's a little bit of confusion. I can understand that, because if you have renal cancer, you're thinking maybe I should be on a renal diet. But a renal diet is really for someone who has kidney dysfunction. Now, sometimes with kidney cancer, there is some kidney dysfunction. You have a nephrologist and they're talking to you about these things. But if that's not the case, you do not need to be on a renal diet. And a renal diet is very complicated. And I'll tell you, when I did my internship and you had to rotate through the different departments when I was in Boston, I ended up on the kidney and the dialysis unit for like 4 weeks. And I sweated it out. There were 12-hour days. I was exhausted. And at the end of it, my internship director says, "Why did you spend 4 weeks on the kidney unit?" And I said, "Well, because you put me there." And she goes, "Oh, that was a mistake." Well, I'll tell you, after that, I said, just give me that kidney diet anytime. I was not afraid of it. But what you can and cannot eat really depends on your kidney function. So only if your doctor says you need to restrict something other than salt, then there is really no reason to be restricting other foods. Okay, we get this a lot. Does sugar feed cancer? So no single food can prevent or cause cancer, including sugar. So sugar as causing cancer or feeding cancer is a little more nuanced. So there's no data that says if you eat 2 cookies that you're going to grow 2 kidney cancer cells. So it's not like that. It's more eating a diet that has a lot of sugar over time, maybe gaining weight, having high insulin levels. And then cancer cells can have things like insulin, like growth factors, that can kind of stimulate the growth. So certainly no dietitian is going to come in and tell you should drinking sodas and having all this added sugar. But we don't want people cutting out a lot of carbs in their diet, or cutting out like fruits and things like that have all these other benefits like fiber and vitamin C. Okay, well, thank you so much. I really appreciated being here.
Thank you so much, Diane. That was wonderful. I've got to change my diet when I get home. So, anyone have any questions for Diane?
Yes.
I'd take apple cider vinegar just to keep it liver away or whatever, but I've also heard that cancer thrives in an acidic environment. Mm-hmm. So, I mean, would apple cider vinegar be good or bad?
Okay. So apple cider vinegar is actually a good part of our diet, but for a different reason. So cancer cells actually create that acidic environment around the cell. So the cancer cell is creating that environment which they do thrive in, which is true. But to be able to change the acidity or the alkalinity of your bloodstream is next to impossible to be able to do, because your kidneys and your lungs and everything are regulating that really tightly. So doing apple cider vinegar is not going to create an acidic environment around your cancer cell. If you're wanting to do apple cider vinegar as part of a healthy diet, that is completely fine.
Thank you.
You're welcome. Hi.
Do these fake sugars that they have, I call them fake.
Yeah.
Meaning anything but sugar.
Right.
That is sweet. Is it okay for does your kidneys handle that well enough, or?
So it seems like the kidney does, but the gut might not. So, when we're really focusing, especially in kidney cancer, we're looking at a lot of immunotherapies. So the majority of our immune system, close to 70 or 80%, is in your gut. And along in your gut are all these trillions of bacteria called the microbiome. And they really support the immune system. So what we're finding is that artificial sweeteners, the chemical sweeteners, we don't know about stevia yet, that's a little bit new, but the other artificial sweeteners that you're used to, like the NutraSweet and the saccharin and those based, do seem to interfere with those bacteria. So they're not completely inert. So dietitians do not recommend that people go from regular sodas to diet sodas. We're trying, if you're doing diet, we're trying to wean you off the diet also and to be able to support your immune system. Good question. Yes?
Diane, along those lines, what do you feel about monk fruit? Those replacements.
Yes, exactly. So monk fruit is a more natural fruit that you're using. It is I would say it's a sugar alternative. So instead of using sugar or cane sugar, you might decide to use monk fruit. What some people with diabetes find is that it has a little better blood sugar response when they're doing monk fruit. So I tell people, you pick your sweetener of choice. Mine is honey. Yours might be real maple syrup. Yours might be monk fruit. But as you're using it, use the smallest amount that you need. And if you try to wean a little bit over a few weeks, you can probably bring down the amount that you're using. Awesome question.
All right, thank you, Diane.
Thank you.
So next is Venkat. He is my right-hand man. Any of you who know me know he's usually not far behind me. He's in clinic, he's in the OR. Many of you who come to my clinic will see him. And it's pretty much just as good as me, in some ways better. So excited to have him here, talking a little more on the surgery-specific side. So thank you, Venkat.
Good afternoon and welcome to Moffitt. See some familiar face in here today. Mr. Trasher, how you doing? All right. So today I'm going to be talking about what to expect after kidney surgery. So here at Moffitt, anytime you have surgery, you could have kidney surgery for small things such as, kidney stones and those kind of things. But here at Moffitt, we do most of our kidney surgery are because of a mass on the kidney. And it's usually the kind of surgery we do is dependent on the size of the mass and the location of the mass. For smaller masses, we do what's called a partial nephrectomy. On larger masses, we do what's called a nephrectomy. We also do a type of surgery what's called a nephroureterectomy, which is involving removing the kidney and the ureter, but that's involving, it's a type of urothelial carcinoma. But I'm not going to talk about that too much today. So pretty much majority of our kidney surgery here at Moffitt is because of a mass on the kidney, a small mass or a large mass, and the type of surgery is either a partial nephrectomy or removing your whole kidney, which is called a nephrectomy. And usually those surgery are done in two settings. They're done in an open settings or minimal invasive surgery. A lot of you guys have probably heard we do robotic surgery. We do a lot of robotic surgery here at Moffitt. So most of our partial nephrectomy is done robotically. It's called a partial robotic nephrectomy. And then we also do robotic nephrectomy. And we also do those surgery in an open settings too, and that's determined by your surgeon. by looking at the mass, looking at your history, are you a candidate for an open surgery versus a minimal invasive surgery. And usually, for a minimal invasive surgery, the length of stay in the hospital is usually anywhere from 1 to 3 days. For an open surgery is usually anywhere from 2 to 7 days, give or take. And that's all depend on how you're doing in the hospital, and your health team is going to evaluate you. Usually full recovery for these surgery is usually anywhere from 6 to 12 weeks, and it obviously is dependent on your patient age, health, and the surgery type you have. Normal activity, we expect to go back to about around 6 weeks. Complete healing about 3 months. So what to expect right after your surgery? After you have a kidney surgery, either a partial nephrectomy or a nephrectomy. Usually at that time you're going to have a Foley in, which is a tube that's coming out of your bladder, draining the urine out. You're also going to have a drain in. Some surgeons do not put drains in, some do put drains in, and that's determined at the time when we do the surgery. A lot of surgeons is a surgeon preference. Some likes drains, some don't like drains. There's always an etiology why we put drain in and why we don't put drain in. But majority of the time, you're either going to have a Foley or a drain. Usually post-op day 1, we are going to remove your Foley, which is the tube coming out of your bladder. And the drain also we usually remove in post-op day 1. But before we remove it, we usually test it for urine to make sure there's no urine in that drain before we remove it. There's other factors going to determine if you remove your Foley or your drain. If your drain is putting out copious amount of fluid, the surgical team may want to know what's coming out, why is it producing so much fluid. Also, if your Foley is putting out urine that's very bloody, those things that they're going to evaluate to determine if they need to keep those drain or Foley longer than expected. Also, while you're in the hospital, you're going to have some IV lines in, and that's usually to maintain hydration, to maintain your kidney functions. You are going to be checked with closely vital signs. Obviously, we're going to check your vital signs, monitor your kidney function. At that time, you're going to have some pain, and that's normal. We're going to be prescribing pain management, usually medication to help with your pain. After these surgery, you tend to have some limited mobility, but that's okay. We always recommend it start increasing your mobility to increase your walking, those kind of things within the room. Some of the expected symptoms that you're going to expect to have. With these surgeries, all depend if you have robotic surgery versus open surgery. Obviously, if you have a robotic surgery and it's a partial nephrectomy, you may have 5 small incision, very tiny incision. Usually they're less than 2 centimeters. You may have a bigger one. That's the one we usually extend to extract the specimen from. So pretty much for a robotic partial nephrectomy, which is where we only take part of your kidney, you're going to have about 5 small incisions, and those incisions, a lot of times, they're covered with glue. We suture it in the inside, but we cover it with glue on the outside. So you're going to have soreness around those incisions. If we do open surgery, the incision site is going to be much bigger because it's a much bigger incision. You're going to be much more tender. So you're going to have a little bit more discomfort from those incision sites. You're going to be fatigued, some weakness, and that's normal. Nausea, that's common from the anesthesia that you're going to have. Constipation and gas, that's very normal right after surgery, and some headaches. Usually around week 1 to week 2, you're still going to have some soreness in your abdomen, and that's normal. Fatigue is still going to be there. You're going to have lack of strength, and that's normal also. Some digestive issues. You're going to have some diarrhea, constipation, gas. That's all normal. Your sleep pattern may change a little bit because of the discomfort from the pain from the surgery. Those kind of things. You can't sleep on one side, depending what side you sleep on, because a lot of these surgeries are based on sides, either right side, left side, or lateral. So that's going to cause some discomfort also. Pain management. We usually send our patient home with some narcotics, and we usually recommend to start taking your pain medication as long your pain is under control. Don't make sure it gets too severe before you start taking it. And usually around week 1 to week 2, it starts to decrease, and it gets a little bit better. We always recommend adequate sleep because sleep will definitely help with the healing process. Start generally, short walks is encouraged to prevent blood clots. Avoid any lifting, pretty much anything no more than 10 to 15 pounds. In terms of what that is pretty much a gallon of milk or a gallon of water. That's what it is. It's about 10 to 15 pounds. No driving until you clear by your surgeon. And usually that's when you're off your pain meds. Usually week 2 to 6, that's when you're going to start to have an increase in energy level. Your strength is going to start to return back. You're going to have reduced in pain. You're going to start get some better in discomfort. You're going to start to feel much better. Your sleeping pattern is going to be better. You're going to start to sleep a little bit more better. Your appetite is going to return back to normal. Your eating habits going to be much better. At that time, you also recommend start increasing those activity levels, like longer walks, lighter activities, gradually return to daily routine. We still want you to avoid strenuous activity or any heavy lifting at that time. Usually around week 6 to 12, that's the full recovery mode. That time you usually go back to work, but it's also dependent on the type of work you do. If you're a desk worker, you may go back a little bit sooner. If you do physical activity or strenuous jobs, it may be a little bit longer. So again, normal activity is usually returned within that time frame. Exercise, as long as it's approved by your surgeon, and usually driving is usually clear by this point. So some of the symptoms you need to call your surgical team about is, one of them is, there's multiple of them here, but all of these are very important, especially if your temperature is above 101, if you have significant pain not controlled by your pain medication, you have sign of infection, redness, swelling, any discharge from your incision sites, you start having some urinary symptoms, such as burning, frequency, blood in your urine, any breathing problem, shortness of breath, chest pain, any swelling, especially in your legs or abdomen, any persistent nausea or vomiting, any inability to keep food down or fluid down. Some of the complications from kidney surgery, obviously you could have an infection, you could have bleeding, because anytime we operate on our kidney is a very vascular structure. So it could bleed post-operatively. You could have blood clots, you could have pneumonia. Those are, some side effects, some surgical risks, urinary tract infection, and a change in your kidney function. So anytime we operate on your kidney, there could be a bump in your kidney function, and that's why we usually monitor the labs very carefully. Around week 2 to week 3, you're going to meet with your surgical team. Usually at that point, you usually meet with the surgeon. If not, you meet with the surgeon APP or mid-level, or one of our surgical APP in the GU department. At that time, they're going to take a look at your incision site, make sure it's healed properly, make sure there's no sign of infections. They're going to do a complete assessment, assess for your pain, how you're feeling, any side effects related to your surgery, any complication that you had from your surgery. At that time also, you're usually going to have some post-op labs. We're going to compare your labs from before your surgery, before you had your surgery, and after your surgery to see, did your kidney function take a bump? What did it do? Is it up, is down? If it does take a bump, we usually recommend some consultation with a nephrologist to try to maximize that kidney function. At that time also, we're going to review your pathology. And this reviewing the pathology will determine what's the next step is in terms of surveillance. Do we follow you up? Do we add any treatment after that? So pretty much your surveillance is categorized in two risks, is high risk and low risk. So low risk are usually small tumors, and that's most of the situation we see here at Moffitt. Is usually small tumors, and they're early stage 1 or stage 2. They're low grade. Surgery remove it completely. So what are the follow-up for these low risk pathology? So the follow-up is usually the guidelines of following you every 6 months for about 2 years, and then annually. And what that involves imaging scans, and imaging scans of your abdomen, and imaging scans of your pelvis or your chest. And those imaging scans could be CT scans or they could be MRI. And those scans are dependent on your kidney functions. If your kidney function is abnormal or there is renal insufficiency, your provider is going to make a modification and says, okay, let's have an MRI rather than a CT scan to preserve that kidney function. You're also going to have labs. We're going to, go over all your labs that how often we need to do it. And usually it's a time frame of every 6 months or so. And usually we're pretty good here at Moffitt. We tend to, majority of the time, most patients will see the surgeon the first visit, followed by an APP the second visit, and then we flip-flop it. Try to keep it at least every 6 months to see your surgeon. Is it perfect? No, it's not perfect. So sometimes it goes a little longer. But that's our goal here, is to try to get it every 6 months to see your surgeon. Then we go to the high-risk pathology, which is a larger tumors. They're usually stage 3 and stage 4. They're higher grade, and they have other concerning features, histological features. So these pathologies, we're going to follow you very closely. We're going to follow you pretty much every 3 months for 2 years, and then we're going to start increase your interval of surveillance. Those scans are going to be the same, CT scans, MRI, and those scans is going to be based on your kidney function. What is it doing? If you're renal insufficiency, we may do MRI. If you have good kidney function, we do CT scans. Well, pretty much every 3 months, very closely. And we're going to follow you for a longer period of time at that 3-month interval and start increasing. At that time, we're going to have a discussion about the role for adjuvant treatment, which is decrease your risk of any reoccurrence of cancer. We're always going to recommend a consultation with our medical oncology team here at Moffitt to have that discussion with all the risks and benefits of adjuvant treatment, because it's very important to understand the risk before you start anything. So we recommend you talk to our medical oncologist. So the most common questions we usually have with my cancer come back. Most kidney cancer that are completely removed do not come back, but it's also specific based on your stage, your grade, and your type of cancer you have. So that's why we do surveillance. We want to make sure we catch anything if it does happen. Remember, we're surveillance you, we're watching very carefully, and treatment keep getting better each time. Final thoughts: having kidney surgery and dealing with pathology result can be overwhelming. Remember, you've taken an important step by having kidney surgery. Most people do very well after kidney surgery. Follow-up care help ensure better outcomes. You can live a full and normal life, and we're here at Moffitt to support you. Okay? Any question?
Yeah, go ahead.
So I have had immunotherapy. I have stage 4 kidney cancer, but I've had immunotherapy now for 2 years. I still have my kidney, the mass was on the outside, and the kidney is functioning. The mass appears to be dead, as well as some of them are completely gone, and some of the lungs are still there, but they all appear to be dead. So, and I have come for a consultation, but I can't figure out whether it's a good thing to remove the kidney at this point or not. And what I'm hearing mostly is immunotherapy is too new, and we really don't know about those dead masses, I guess, and how that can go, how that proceeds, I guess.
Yeah, I'll take it. It's funny, this is what is great about the symposium, because right behind you, you have Mr. Thrasher, who unfortunately, or fortunately, I would say, was sort of the people, when these drugs started coming out and the response rates we saw, people like yourself, where traditionally, even when I first started here, when I saw a patient who had widely metastatic disease and wasn't ideal for a cytol reduction, there's still some of those cases. We started pushing patients more, and it's not just here at Moffitt, I'm talking about those of us who do a lot of kidney cancer across the US and even across the world. We had all these drugs coming and people were responding and living longer, but one of the things we saw, which is not unusual, is that while the metastatic sites seem to go away completely or even shrink dramatically, the primary tumors didn't always do that. One of it is a simple mass, right? These tumors, especially bigger ones, it's just harder to get rid of those cells, right? They can't dissolve and go nowhere, whereas like a 1 centimeter mass in your lungs is a lot less volume. But to your point, and actually one of the patients who was going to be here is sort of in the same shoes, but he wasn't able to make it, is now, traditionally we would see patients have the convected, this great response, everything else is either gone or shrunk, and they still have the mass. And what do we do? And initially, like many surgeons, we were like, cut it out. I don't like it, get it out. But as our experience gained, and it's specific to Mr. Thrasher's case, we started learning that some of these tumors we were cutting out are already dead. And that begs the question, should we have done it in the first place? So my management, and there's no guideline for this, and it probably will come, has now changed a little bit, whereas I'm not as always gung-ho to go in and operate on patients because I don't want to remove a kidney, especially one that may have some good function left into it, without knowing there's some benefit. And so I counsel patients on that before, saying, listen, if we do this, there's a chance that everything's dead, and that's a good sign, right? But it also means you maybe had a surgery you didn't need and lost a kidney you didn't need. So every patient, again, depending on what their kidney function is different. And so as opposed to recently or in the past where I'd go cut it out, I now do biopsies on these patients. So in a case like yours, I would be very interested to biopsy that mass to know it's dead. Now the radiologist can tell you sometimes that, and sometimes it looks it, but other times it's not as easy. And so sticking a needle in it, which is a safe thing to do, can sometimes give you information. Now it's not perfect either. It's still traditionally a lot of patients like yourself, we just monitor closely, and if that tumor in the kidney starts growing, then we sort of get our answer. But I think you're not going to be alone in that more patients will be walking around with 2 kidneys and the primary mass is dead. And we don't have a good game plan for that, but we're starting to learn some things.
Thank you.
Go ahead.
You mentioned that you do an MRI or a CT
Scans, yeah.
depending on the
Kidney function? Yeah.
Why would you do one over the other? Does it hurt your kidney?
Right, so when you have a CT contrast, the iodine contrast is very toxic for your kidney. So if you have a declining kidney function, we do not recommend to have the contrast because it's will affect your kidney function in the long run. So we prefer to you to have an MRI.
So I guess to follow up, because it's a common question, what he said is absolutely right. The contrast agent that is used for MRI is very different from the one that is used for CT scan. The one that is used for CT scan, and I'm sure somebody in this room has an iodine allergy or contrast allergy, right? Those are another reasons we can't always get CT scans. The MRI, the contrast that's used for that is much easier on the kidneys. In fact, the latest ones that they use, and Kerry is always the person I have that has taught me this, actually, is you can in essence give it to people who are on dialysis. Now, that didn't always used to be the case with the earlier agents for MRI. They had this thing called NSF, where you get these wrinkly fingers and people with really bad kidney, and that still has been reported, but at the newer agents, we really don't see it. So the kidney function is a big part of who we recommend CT versus MRI because of that contrast difference.
If you have a good kidney function, you should not have
If you have good kidney function, you could have either, right? There is sometimes an MRI is preferable, but when it comes down, I guess, to the most common scenario, which is my kidney function isn't great, which one should I get? Obviously, that's really the job of the providers, and it's not just me determining it, the radiologists double check things. You have several layers that are, and they usually check your kidney function the day of when they're giving you contrast. If you ever notice, they go by, it looks like they're checking your glucose, but they're not. They're checking your kidney function.
What happens to the dead masses, so to speak? Meaning the tumors or whatever. If they're now dead, what are the consequences of that?
Likely nothing.
Nothing.
So, we learn stuff from other cancers too, right? I do mostly kidney, but I also do testes cancer, and this is a phenomenon that's been going on in testes cancer since decades ago. Testes cancer is very curable, and you can cure it with chemo alone. And what happens to me as a surgeon sometimes is patients, their tumors shrink, these are usually lymph nodes, but they don't get all the way small, they're still too big. And what we know historically from those ones is that if we go in and remove those tumors, but that's usually a bigger surgery, they're around the big vessels, so that's not a small surgery. That there's about, in most situations, about a 40% chance there's any tumor there, there's about a 40% chance it's all dead, and there's about 20% chance the tumor has what we call a transformation sort of change. But the point is that I have to tell patients that before we go in for this major surgery with my testes patients all the time, and now I'm actually doing it with my kidney patients. But for those testes patients that basically don't choose to do surgery because we think it's all dead, I followed those patients for decades and nothing has ever happened. So again, different cancer, some different biology, but sort of answers your principle.
Yeah.
But it still feels agonizing to patients, and I'm a surgeon, so I'm in your same shoes. oh, there's tumor still inside, get it out. But that's not always, logic in the human nature, I feel, pushes at that, but that's not what the data says.
How do you know the tumor's dead?
Yeah, that's a great question. So the only way we know for sure is cut it all out. But depending on the complexity of that surgery or the risk to that patient, that may not be worth it. So you're not crazy if you said, I just want it out because I want it out, so you can tell me 100% it's dead. Depending on the risk for that patient, that may be a viable option. But for other patients, the consequences can be more severe, right? You got a patient who already has not good kidney function. You got to go remove that other kidney. You don't know if it's going to help them. That's a very different question. So those are the patients where sometimes, to your point, I'll get a CT scan. If I don't like the CT scan, I'll get an MRI, hoping it gives me more information. I don't like that, I'll get a biopsy, hoping it gives. But there is a runway, and that runway runs out, and we have to, as a patient and physician, come to an agreement on where we want to put our risk. A risk of surgery, that maybe you didn't need it, or a risk of watching it, and we possibly missed that window. Yeah?
Yes, thank you very much for that brilliant presentation. Considering that age may be a factor of you developing a kidney issue because you can't work properly, and then after a lecture like this, part of your annual visit to your primary care, is it important for you to request for a kidney test to be done for you?
I'll let Ben take this one because I'm sure he gets that question a million times.
So your question is it routine to have a routine scans to evaluate?
I'm just asking. I'm sure you have a primary care that you visit all the time. I'm considering age that may be a factor for you to have a kidney issue. Is it important for you after a lesson like this, which we are undergoing now, is very important. It's important for you to request in front of primary care.
For primary care? Yeah, and that's a good question because, human nature, we want to scan to see what's going on, right? We want to scan to see if we have a mass or we don't have a mass. Unfortunately, we start scanning each patient, you're going to start finding different things. So yes, usually kidney masses are incidental finding, and we base it on symptoms. We go by, if you have urinary symptoms, you start having pain. Pretty much is basically diagnosed by, you're using symptoms, you start having symptoms, that's when we do scans. But we don't recommend routine scans just like that. Some provider will do some ultrasound scans. If your kidney function is abnormal, it starts declining, like on renal ultrasound to see what's going on, to see is there a baseline, some stones or something that's causing that. And then usually that sometimes picks up some mass, but usually now we don't do that all the time.
Do the treatments that they have, do they change your DNA?
No. God changes your DNA. All right, we're going to get going here. Thank you, Ben. Really appreciate it. All right. So next we have Sarah, who is our social worker in GU. She's another person that's sometimes behind the scenes for many of you, but for some of you, she is one of the more important person too. I think Dr. Chahoud's talked about this. Other talks have talked about this, right? We can have the best medicine, the best treatment, but access to care for patients is a major issue, right? Not all of us are fortunate, like you in here in the room, to be able to make it either because of the logistics, the finances, the work, the family, all those kind of things. Those are huge stressors. So we can have the best treatment, but if a patient can't be here and follow that treatment, then they're not gonna have the best outcome, and that's where Sarah really helps our team out. So thank you, Sarah.
Thank you. All right, thank you. Good afternoon, everybody. So I'm kind of going to go through things a little bit differently. I'm not going to be looking at numbers because everybody is a human being and there's so many different factors that are going on in your lives before you step foot in this building. People are thinking about retirement, you're thinking about graduations, life events, all these things that you've been working on for so long. And then a diagnosis comes out of nowhere and now it's like, what's next? What's happening? So I'm an outpatient social worker, so I'm available within the clinic, like the GU unit here. We have inpatient social workers that are here if you're having surgical or some sort of like medical intervention where you're being admitted. We have multifaceted teams that are available within our department to help support people. And that kind of level of support looks different for everybody. Some people, it's questions of advanced care planning. Have you ever sat down and had to think to yourself before of, if I can't make a decision for myself, who am I gonna put that on? Because a lot of people, they think it's kind of a scary conversation because you don't want to think about what is the end, who would be the person I trust to put in that place. So having these kind of tough conversations are very important. A lot of people also have a lot of financial concerns, like, you know, some people are not coming from 10 minutes down the road. We've got people coming across the state internationally that are coming here for care. And it's the question of, do I choose to eat today, or do I choose to get my cancer care for some people? So it's kind of these tough conversations and getting access to these resources to make sure you have that longevity that you've been wanting for so long. And there's a lot of emotional components too. It's someone just told you you have a diagnosis of cancer. That can be extremely terrifying for people because you didn't know that was coming. That can come with thoughts of fear. You have no idea what's coming on. What is the next step? You have these racing thoughts that you can't control in that moment. So a lot of conversations about how are we going to cope with this diagnosis and move forward are so important. And then a lot of other things like community resources. Do you need a walker because you're declining and you can't stand on your own? Do you need lodging if you're coming from long distances? Where are you going to stay when you're getting your care? It's very important for us to have these conversations. So I wanted to kind of put this in the form of a person. So this is Anna. Anna's a 35-year-old female. She's married with a 10-year-old child. So she's coming from the Orlando area. So she's going to have to come from some distance to get here. So that's going to be that logistical conversation of how are you going to come from Orlando to come to Tampa to get your access to everything you need. And Anna's being told that she's got to have a nephrectomy. She's going to have her kidney removed. So she's going to be potentially recovering from that in 6 weeks. So she's got 6 weeks to plan of what am I going to do next with her family. So this would be where social work comes in, and we're very helpful as far as emotional support. Do you need counseling services from yourself? Are you finding yourself in a place where you can't move forward past today because you feel like you are so crippled with your anxiety that you don't know what to do? So a lot of that is conversations about coping with your diagnosis, depression, grief. If you're going through a cancer diagnosis, you can potentially be grieving what you thought was going to be your normal life being potentially taken from you. So a lot of that is facilitating conversations, connecting with other patients your age, people who understand what you're going through, who've walked in these shoes. Within Moffitt, we have virtual support groups that are available for people. So anyone who has a cancer diagnosis to be on a virtual support group with another patient, or for caregivers and family members to talk to other patients and family members to have that connection. The Kidney Cancer Association is a great resource, as well as Emmerman Angel, to kind of get those peer-based connections. And for people who are a parent or a grandparent that is taking care of a child, we do have programs that are available to help assist additionally with that too. Meaning, maybe you have a young child and you have to have the conversation of, hey, I have a diagnosis, and needing to know how to have that conversation at a very age-appropriate level. So we have a program with our Families First within Moffitt where we provide backpacks that are age-based for children. So that has a comfort item and a little information about like books or things of how to bridge that conversation with somebody who's very young and fragile that doesn't understand what they're going through. And we partnered recently with Camp Kesem. It's a summer program that's local for people who have children and they just want to navigate these conversations and meet other parents and guardians. And a big thing that we do is advocacy. So you have this diagnosis, you have this treatment coming up. Maybe you feel like the team isn't hearing you. So sometimes being a part of that conversation, social work can join in with you and help advocate to make sure your voice is heard in a way that you feel like everyone understands where you are coming from and how you want to move forward for the next day. And a lot of that too, with that conversation, like I said, advanced directives are so important, making sure that your autonomy is going to be fulfilled for you. And then with Anna, being 35, if somebody gave you a diagnosis when you're young and you're 35 years old thinking about having additional children, having that moment of, do I need to do fertility preservation to ensure my ability to have children if I have any reduction in eggs or anything like that, to make sure that that is still going to be part of your options. And then care coordination, so kind of seeing how we can be available to assist. So I frequently work with the medical team in a status of the patient is informed that they have cancer. We step in and we are in that conversation of what is next. How are we going to plan out what's going to happen? Do we need to work on the logistics of getting here? Do we need to work on the emotional support? Maybe we need to get you a peer connection because you really feel like you could benefit from it. So it's a lot of interfaceted connections between inpatient, outpatient, and within the community. And then practical support. So transportation. I know it was mentioned earlier, some people are not able to drive for 6 weeks after their surgeries. So making sure that you have that planned ahead of time, because if you are used to driving yourself all the time and someone suddenly says, hey, we can't do that today, that's maybe a conversation that needs to happen to make sure that you are safe. And then financial aid conversations. If you're, example, Anna, so you're 35 years old and you work and you're part of the sole income for your home, having that conversation of, hey, maybe we need to look into disability, start to do short-term disability applications, and do we need to fill out for any community grants to make sure that we're not concerned about rent, food, or any of the necessities in life so we can try to focus on your cancer care. So overall, kind of connecting with social work, it's kind of assisting in our overall well-being. So it helps with our adherence, making sure we get to Moffitt, we're available, we aren't concerned about, hey, can I make it next Tuesday? Having that conversation to make sure we're able to be here. And then we're here for very complex conversations. Sometimes, unfortunately, that is, we're having surgery, or maybe we have to think, is this the right choice for you? What is your goal? And if it's anything for end of life, making sure that everybody is with their comfort. I've included our office if anyone wants to take it down to connect with social work. That's how to get a hold of us. And any questions? Great, thank you.
Next, we're going to have Dr. Grass come up and talk to you a little bit about radiation in the treatment of kidney cancer. This is sort of a newer field. In fact, we had one of these symposiums, I think 5 years ago. Dado, did you talk at that one?
I did not.
No. So this wouldn't have been part of our talk about 5 years ago, which tells you, again, this is an emerging treatment option. It's been around for patients with stage 4 for quite a while. Mr. Hopkins gave sort of good examples, but it is also moving into primary treatment. And there's still a lot to be figured out, and Daniel can go over some of that, but it's important, I think, to start recognizing, again, many of you here may have already been through treatment, but for those of you who know, this 10, 15 years from now may become more of a standard option. So thank you, Daniel, and excited to hear your talk.
So thanks for the opportunity to come and discuss today about the utilization of radiation in the management of kidney cancer. So during this talk, we're going to briefly go over what radiation is and the different approaches of it. How radiation can be used in the treatment of patients who have localized or non-metastatic renal cancer, how radiation may compare to other interventional radiology ablative treatment approaches, and then conclude with how radiation may assist in patients that have metastatic kidney cancer. So what is radiation therapy? So radiation is the delivery of high energy X-rays from outside of the body, multiple different angles towards the target of interest. And in this particular case, you can see that those radiation beams are targeting a tumor that is within the actual kidney. And so what we believe happens is that radiation goes in there, kills the cancer cells, and then over time, the healthy tissue that is around it begins to heal itself. So radiation in general has been absent from RCC treatment for several decades, and there are several reasons for that. But one of the main ones is that radiation has had a reputation of not being as effective in kidney cancer. And so the term that we would use is that kidney cancer is radio resistant. And this is because the older studies that evaluated patients treated with radiation demonstrated no improvements in their outcomes. And so for this reason, surgery, interventional radiology, ablative procedures, and systemic therapies have kind of been the main treatment approaches for patients with kidney cancer. And this was about until the early 2000s, where there started to be a lot of advancements in the way that radiation is delivered. So if we use this here as an example to kind of describe how radiation has evolved, you can see in the top left panel, there's kind of a mold of a guy. And then you can see right next to that, there's a block. And so if you use the way radiation used to be practiced many, many decades ago, and let's say we were just trying to target something that's in a patient's pelvis, it's just like an x-ray coming down and you really can't see anything. And so if the goal is to try to make the radiation beam as close to the way that the figure looks, you can look at that block next to it and you can say it's not very precise, right? It's just a block. It's not following the contours of that model. So if we fast forward to the next level of radiation, now you get into three-dimensional radiation, where you can look at that figurine, and now you can see that the radiation can actually carve around that target a little bit more, and it looks a little bit more like a person and not just a block. And then if you look at the example down in the pelvis, you can see the radiation's going through the pelvis. But if the goal was just to treat, let's say, the lymph nodes that are sitting in the pelvis, it's really not only targeting that area. It's hitting the bowel that's in that region. So then we fast forward a little bit more, and we get to three-dimensional radiation, plus a way to sculpt the radiation beams as they're being delivered to the patient. And now you can see that that block has become this beautiful artwork where it looks very close to the way that the original was. Now that's a little bit of an exaggeration, but that's what we kind of think when we're delivering this more advanced radiation approach. And you can see at that bottom panel on the right is that the overall goal here was to treat the pelvic lymph nodes. So not only can you see the anatomy, but you can also see that the radiation dose sculpts very nicely in that pelvic lymph node area. So this has continued to evolve even further, where we can create videos of patients as they're going through treatment. And if we take, for example, kidney cancer, when you breathe, your kidneys are going up and down. And so if the goal is to just treat the tumor in the kidney, we can create a video of how the patient breathes, and we're watching this in real time, and we have advanced technologies that if the tumor target goes outside of this margin of error that we create, then the radiation beam is not even on, okay? And that's called adaptive radiation, and that's also technologies that Moffitt has here as well. So when we think about the classic radiation of what I was indicating has shown not to be as effective for patients with kidney cancer, this was usually a low dose of radiation for each treatment, which we also call a fraction. This also included those larger treatment regions, which weren't very specific, and usually that radiation approach is over more than 5 weeks. When we talk about the more advanced and focused radiation, a term that we call stereotactic ablative body radiation, or SABR, then this is high dose radiation per each individual treatment. The target areas are much smaller, and usually this can be delivered in a single treatment or even up to 5 times. So I hope to convince you, during this discussion, that the response of kidney cancer is actually much greater when you use this higher dose radiation approach compared to the older low dose approach. So the first thing that we're going to discuss is the management of patients who have non-metastatic RCC, so stage 1 kidney cancer. And so currently there's about 15 prospective trials out in the literature, roughly about 300 patients. And what it shows is that there's a range of about 75 to 100% probability that the area that is treated with that high dose of radiation, which I'll call SABR, can lead to really good tumor control. And so currently the highest quality data to date is from this clinical trial called Fast Track 2. And in this trial, what they did was they took patients who had primary RCC. These patients were not fit to undergo surgery, or they declined surgery. There were 8 centers that put patients into trials, which was about 70. And then the SABRE was delivered as a one-time treatment or a 3-time treatment. So at about 3.5 years of follow-up, not one patient has had a recurrence in their kidney that was treated. 97% of those patients have also not had their cancer spread at 3 years of follow-up. Only one patient out of those 70 needed to go on dialysis because their kidney wasn't working as well anymore. And overall, the study showed there was really no severe toxicity in those patients that were treated. So you might say, well, doesn't SABRE impact kidney function? Well, the answer to this is that yes. So this is an image that's demonstrating the function of a kidney using an imaging approach. And the green represents the area where the kidney tumor is at, and that's where we'll say 100% of the radiation dose went to that area. And if you follow that green circle as you go from the 12 months to 24 months, you can see that that brighter signal actually starts to go away in that region. And that's because the radiation has killed the cells in that area, so therefore the kidney function has gone down. This would kind of be a very similar association that you would think if you underwent a partial nephrectomy. You remove part of your kidney, so therefore it's not working anymore. So if you think of radiation as a virtual surgery, it has led to the same effect. So the study demonstrates that patients can expect about a 20 to 30% decrease in their kidney function over the course of 2 years, but then it plateaus. And so this is why it's very important that if you are to undergo SABRE to the kidney, that you need to have a good baseline evaluation of your kidney function. So then you might ask, well, what if I only have one kidney, but then I develop a cancer in that only kidney? And so this is a pooled analysis of 81 patients who were treated with SABRE to that kidney. And what they found is that the ability to control that tumor was almost perfect, and not one patient had to undergo dialysis. So this demonstrates the feasibility as well as the safety to give patients an alternative treatment option who meet well-selected criteria to utilize this to help treat their kidney cancer. So how does SABRE compare to some of the other non-ablative interventions that are out there? And so these could include radiofrequency, microwave, or cryoablation. Now, all of these are considered to be non-invasive or minimally invasive. And so there was a recent study that came out of about 9,000 patients where they were treated with one of these ablative approaches. And what the data shows across all these different treatment methods is that SABRE had a numerically higher local control rate compared to all those approaches, especially when the tumor was greater than 4 centimeters in size. But what's really important about this is that all of these treatment options for patients were associated with low side effects overall. So this requires good multidisciplinary discussion with your physicians, yourselves, your family members, etc., to try to navigate the process to figure out what is the best option for you if the surgical treatment approach is not what you're going to go through. So, in general, SABRE for a primary kidney cancer has excellent tumor control, low toxicity. Overall, the risk of having to go on dialysis is less than 5%. Compared to other ablative approaches, if the tumor is greater than 4 centimeters, there is encouraging data out there that said that SABRE would do a better job at controlling that tumor. And SABRE is actually recommended in many guidelines across the world as a treatment option for patients who may not be the best surgical candidates. This other image here on your right compares SABRE versus surgery versus some of those ablative approaches. And what you can see is that SABRE does not require anesthesia. SABRE will not be limited where the tumor is located in the kidney. So if it's in the center area near the blood vessels or the ureter, we could still do SABRE in that region. The tumor size, as long as it's confined to the kidney, should not be an issue. and also SABR is non-invasive. So overall, encouraging data continues to emerge regarding the use of SABR in the management of patients with non-metastatic kidney cancer right now for patients who are not good surgical candidates or who do not want to go through surgery. So now we're going to shift to discussing the use of radiation in the setting of patients who have metastatic kidney cancer. So right now there are 11 trials that have been out in the literature, roughly about 350 patients. And what that data says is that the area that is treated with SABR, you can anticipate 80% plus chance that that site can be controlled with radiation. It's really important to indicate that that does not mean that another site pops up. So it's the specific site where radiation is being treated where the local control is at. So in the setting of metastatic cancer, as we continue to learn more about our patients, there's a newer concept that has continued to evolve. And we know that we cannot put all patients who have metastatic kidney cancer into the same bucket. And so there's information out there that says that patients that have a low burden of metastatic disease, which is usually less than 5 total sites, not including the brain, then that term is called oligometastatic disease, where oligo means few. And so there have been 2 prospective trials that have looked at patients with oligo or few sites of metastatic disease. One is a phase 2 trial, 23 patients. All of these patients have not received any systemic therapy. They had less than 3 sites of disease. SABR was delivered to all of those sites, and the treatment was either 1, 3, or 5 total treatments. At 1 year, they found that 91% of patients did not need to go on systemic therapy yet. The second trial is in 30 patients. All of these patients had oligometastatic disease. In this one, it was less than 5 sites of disease. Radiation was delivered. In this one, 30% of the patients had prior systemic therapy, and 50% of those patients were what we would call in a favorable risk group. And what this study found is that 1 year, 82% of those patients still did not need to go on systemic therapy. So what about if we think about SABR with the use of some of these more novel agents out there like immunotherapy? And can delivering radiation to a site help the patient's immune system work better with that drug? So there's a concept out there that if you deliver SABR to some of the metastatic sites, but not all of them, then there can potentially be this cross-reaction between tumor sites, and therefore your immune system combined with the immunotherapy may help reduce the other sites. And this is called the abscopal effect. Now there's been various trials that have started to evaluate this. So when you look at single agent immunotherapy combined with SABR, the response rates are really not that great. When you go to double agent immunotherapy combined with SABR, we see that that response rate actually gets a little bit higher, up in the 50 percentile. So what this says from this data is it's safe to deliver SABR and immunotherapy medications together, but we need to do more research, more work to understand the best way to optimize this. And I think a good way of thinking about this is the Goldilocks principle. You have to have the right tumor biology, you have to have the right immune response in the patient, and you have to have the right radiation dose to that tumor for everything to just fit just right, okay? And currently we don't know the just right process yet. So what about if you are on systemic therapy and your cancer is progressing on that drug? Where does SABR fit into that? So there's one prospective trial on this right now. It's in 20 patients. These patients have gone through multiple lines of therapy, whether it be a TKI or immunotherapy or the combination of those therapies. They had no more than 3 sites of disease that were progressing, and Sabre was delivered to all of those sites. And what was found in this is that 70% of patients were able to delay going on the next line of systemic therapy at least 6 months. Very encouraging information. So, in summary, Sabre to metastatic sites, lung, bone, lymph nodes, may provide more than an 80% chance to control the disease at that site. But sometimes patients can develop cancers in other sites, and so that's an important thing to consider. Remember, Sabre is like a virtual surgery at that area. In upfront oligometastatic disease, less than 5 sites of cancer spread, Sabre may be able to delay systemic therapy for up to 1 year in about 90% of patients that are well selected. In patients who have progressive disease while they're already on systemic therapy, Sabre may provide them the opportunity to delay going on the next line of therapy by about 1 year. More research is needed to optimize how we combine Sabre with systemic therapies, with surgery to improve our patient outcomes as we continue to move forward as this fight against kidney cancer. So I thank you for your time today, and I'm happy to take any questions.
Awesome. Any questions for Dr. Grass? Yeah.
So I have lymph nodes that are big because of cancer. Would Sabre be able to go in and treat that? I have stage 4. I have stuff all over the place.
Thanks for your question. Not knowing the specifics about your situation, what I would say is usually it's a conversation between a radiation oncologist, your medical oncologist is treating you. We look at where those lymph nodes are situated in your body relative to, let's say, the normal tissue. So if your lymph nodes are kind of in the middle, you're dealing with your bowel that's very close, your liver, your spinal cord. And so you can think of Sabre, and I think this was mentioned by one of the patients earlier, it can act like a spot welding. Okay, so when you have metastatic disease, Sabre can kind of go in there and it can spot weld that area and give you a really high chance that we can control it. Okay, now if the grouping of the lymph nodes is getting very, very big, then sometimes that can become a little bit more challenging. And so this is why it requires good multidisciplinary discussion between your providers.
Okay, thank you.
Doc, when you have the metastatic cancer, and say in myself, okay, I had it and they spot welded my, that's all.
You were the one that said that.
Yeah. Well, heck, I lost it now. Metastatic cancer, when it actually hits the kidney, does it damage it? I mean, when they did me, they had to put little tattoos on me so that they precisely got the right area. Is that equivalent or similar to the Sabre or not?
Again, not knowing the specifics of your situation. Usually, if your radiation treatment is going to be under 5 total treatments, then there's a high probability that you receive Sabre. So Sabre is a very focused approach with a high energy of that radiation for each individual treatment.
I see.
And so usually, yes, we do put tattoos, little tiny, blue dots that will go on your skin.
That's it.
Yep, and that's so the lasers can kind of all come together. X marks the spot, and then there's a whole bunch of complicated physics and computer work that goes on in the background.
Yep, thank you.
So you made the comment, maybe I misunderstood, but you made the comment that if you're going to have radiation, it's 1 to 5 treatments, it's going to be Sabre. So is there a reason that you would have, I guess, regular radiation instead of Sabre?
It's a great question. So in the setting of kidney cancer, regular radiation has not been shown to be as effective, okay? There are other cancers where we do deliver regular radiation and it's highly effective. So in general, if you're doing SABRE to the treatment of the kidney, you're probably going to get 1 to 5 treatments in total, okay? If you were doing SABRE to a metastatic site, you're probably going to get somewhere between 1 to 5 treatments in total. If you get in an area where the anatomy is more complicated and it may be more challenging to deliver SABRE, sometimes radiation oncologists will increase the duration of that treatment, but most times it's not going to go over 3 weeks for kidney cancer.
All right, can't you have too much?
Is this all in trial? Because this sounds like it would be, the perfect ideal answer for, eliminating tumors. But is this all in trials now, or is this treatment?
So what I would say is that usually the way that a patient who gets kidney cancer, they'll usually see, a surgeon like Dr. Manley, and then he will have a discussion with you about surgical options. If you are not considered to be a good surgical candidate, so you have a lot of other medical issues or something else, then there will be multidisciplinary discussion to see what approach you could undergo, whether that be SABRE, whether it be one of those interventional radiology approaches, the cryo, the microwave, okay? So that would be the first thing. When you have metastatic disease, then usually what you'll see is a physician like Dr. Chahoud, who gave a talk earlier today, and they'll talk about giving you medications that go throughout your whole body, okay? Because if it's escaped to one location, then there's a higher chance that you could be trying to go to another location. And currently in the world today, we don't know how to select the best patients to choose to do SABRE, assuming that's the only site of their disease and something else is not hiding, okay? And so that's why getting the drug that goes throughout your whole body and is targeting cancer attacks it in a different way than SABRE. Because you think of SABRE like a virtual surgery. It's going at that exact spot. And so to answer your question, no, this is not trial. There are trials that are ongoing, but this would be considered a very viable treatment option for a patient who has cancer that has spread, but specifically within the bounds of what I discussed, less than 5 sites of disease. Okay?
Okay, yes. Thank you.
Now, is there a possibility of over-radiating, and what are the consequences of that?
So I've been doing this for a long time. No one's grown a third arm or turned into the Hulk. All right. So I think let's get that out there. So with any type of treatment, there's always this fine balance of trying to treat enough to kill the cancer versus not exposing a patient to too much increased risk that causes them issues with toxicity and their quality of life. And so within that dynamic, there's a lot of thinking that goes into the radiation planning. Again, let's say the gentleman here said he had lymph nodes that are kind of in the middle of his abdomen. And let's say he only has 1 kidney. I'm just making stuff up, okay? But let's say he only has 1 kidney and he has this cancer that's growing here and he's been on drugs and they're just not working as best as they could. So now what has to happen is that he would potentially come and do a consultation with someone in our group, and we would say, okay, well, can we deliver radiation to that? But what we have to now consider is he has 1 kidney, so I've got to do everything I can to protect that kidney because I don't want to put him on dialysis, right? 2, his bowel is sitting all right here, so I need to protect his bowel because maybe he was on immunotherapy and maybe he got diarrhea or colitis, which was being talked about, so I need to protect that. He's got a spinal cord back here that I've got to protect, right? So there's all these different things that come into it. And so when you use a term like over-radiation, I wouldn't necessarily frame it like that. I would just say that there's a lot of complex thinking that has to go in, which is very personalized for every single treatment on the way that we have to approach where their cancer is located.
All right, thank you, Daniel. Last but certainly not least, you met Ben, who's my right-hand man, and this is my left-hand woman. I'm left-handed, by the way. That's not to say she's second. She actually is our research study coordinator. She's part of the NITRO group, which is our non-therapeutic research operation group. So many of you here saw Dr. Chahoud talk about clinical trials. That's obviously a big thing we do here at Moffitt. But sort of, again, behind the scenes, and I say behind the scenes because if you ever come to our clinic, you probably see her team, because they're running around all the time consenting patients, because a lot of the research we do here, before it leads to the drugs that leads to the patient, has to start sort of at the basic level, so to speak. And so us getting samples, whether it's tumor, blood, or urine, sometimes we want stool, we'll ask for a lot of stuff. But we're all doing it with the idea of finding new ways that cancer works so that we can expose them, treat them, use it to our advantage. And it starts all with you as the patients. Now, this is something that is not required. We treat you the same whether you do this or not, but many patients, and again, Patel would do this if you came to the clinic and she would talk to you, but this gives you a sense of what those kind of studies look like and how they can help patients. And if you're interested, obviously they have a table out there. I think many of you already stopped by to say hi, but I appreciate Patel taking the time, and go ahead.
Thank you. Like Dr. Manley says, I work with the NITRO department. I'm a research study manager. I've been working with him for the last 3 years. So I know a thing or two about kidney cancer. Today we're gonna go and describe the difference between non-interventional studies versus a clinical trial. I'm gonna talk a little bit about our non-therapeutic research office, better known as NITRO, and the Total Cancer Care Protocol, which is the largest protocol we support as an office. I'm also going to give you a brief description of some of the studies that we're working on regarding kidney cancer, and highlight the impact that you have as patients in kidney cancer research. So whenever we approach patients in clinic, sometimes they seem a little confused, or they think we're gonna offer them treatment options. So we found out that there's like a lot of confusion when we talk about research. So a non-interventional study is where it is basically an observational study that no treatments are given to the patient, and doctors or investigators just follow their standard care that the patient has in the hospital. There are low or no risks at all when you participate in this kind of studies, and the goal is to help understand real world outcomes. Meanwhile, on clinical trials, patients may receive a new drug or therapy. The care may follow like a standard research plan, not necessarily it is a standard of care. This may involve different tests or side effects, which can increase the risk of participation. And the goal is to test if new treatments are safe and they work. So going to talk about the non-therapeutic research office, we support like all non-interventional studies run by any Moffitt investigators. These studies can be about cancer prevention, early cancer detection, different initiatives aimed at improving healthier lifestyles. We can use surveys or different educational sessions for that. And the main goal of NITRO is to enhance and personalize cancer treatments and improve prevention and diagnosis methods. Like I mentioned, the largest protocol supported by the NITRO office is the Total Cancer Care Protocol or TCC. This study is an observational study that we offer to all of our patients that come here at Moffitt. And you may see our coordinators in clinic running around. And you can think about this study like an umbrella study that a lot of the investigators use to gather information, blood samples, tissue samples from different diseases to be able to run their own studies. Right now, there are more than 167 participants with and without a cancer diagnosis, and patients can sign up at any time. If you're a patient here, you may have seen like the link popped up in the patient portal, or you can also be approaching clinic. The Total Cancer Care helps discover new ways to prevent, diagnose, and treat cancer. And this works toward personalized medicine, making treatments more precise and effective. And like I talked to you earlier, the non-patient participants are also welcome to enroll. These samples will serve as control and help us like make a comparison between those samples and samples from patients with cancer. I'm a very visual person, so I think that workflow and diagram will be helpful. So this is how basically TCC works. We obtain the consent form, and once we have that consent, patients basically give us permission to access their medical records to gather any necessary information that investigators may need in the process. We may collect any excess tissue from any procedures or surgeries they have here, and we may also collect blood samples. Once we have like all the information gathered, we perform the different research studies, and then those research studies can lead to publications or better treatments, etc. So, what are we studying regarding kidney cancer? We have a few studies up and running, one of them being regarding clear cell renal cell carcinoma, CCRCC. And on this study, we are learning about the kidney cancer at the tissue level. Basically, we want to explore abnormal gene changes called splice variants and how these changes might affect how the cancer behaves. And we are also looking for clues or biomarkers in the blood and urine, as well in the tumor tissue that we collect from patients. And we're trying to see if these gene changes can be found in those samples, and this might help predict cancer recurrence or how well the treatment is working with each individual patient. The other study that we have is about papillary renal cell carcinoma, or PRCC. And on this study, we're also collecting blood and tumor tissue, and we're analyzing the blood samples to identify the biomarkers or the clues that may indicate how well patients with PRCC are responding to the treatment. And we're also looking at how cancer cells and their surrounding changes during the treatment, and how whether these changes are linked to a person's genetics background, specifically with African American patients, because it's known that this particular type of kidney cancer it's more likely to happen between the African American patients. And overall, all this work can help us to better personalize care in the future. So why patient participation in research studies is so important? Basically, you are the backbone of research, and we use all the information you can give us to advance science, to drive that personalized medicine in the future. We can improve clinical design of different studies. We can accelerate drug development, because the more research participation there is, the more data we have, and the faster we can get the results that we need. We empower the patient voice by you allowing us to receive your feedback and explore whatever happens to you when you are receiving treatment. You help us with that too, and you're creating a legacy of hope for those cancer patients at the moment, and those future cancer patients as well. And that's all that I have for today. This is my contact information. If you ever have questions, feel free to reach out. The QR code leads you to the TCC website, and you can also walk by our table if you still have questions or concerns about the study. Thank you.
Any questions for Paola? No, Excellent. All right. Well, first of all, I want to thank all of the speakers today. They did an excellent job. I'm hoping all of you at least got a little piece of new information or some information that makes you think you weren't crazy in the first place. So either one is probably good. Again, a big thanks to Karen Irby Paola, who just spoke here, was also instrumental at PBAS. The KCA, Gretchen, Kendall, Amy, there's too many people, and then everyone from Judy Nicholson, amazing. But I also want to give a big thanks to you, the patients. Yes, all of us here, we're on a team, but you are the people that inspire us as providers. The stories we've heard today are ones that many of us who are patient-facing get to hear all the time. But for many of the team members you met here, they don't get to always hear that or see that or follow up with you. By you showing up here and showing how well you guys are fighting this disease or have beat this disease and are now helping others is really an inspiration to us. So thank you to all the patients for what you guys do. Yep.
Survey.
What?
Survey.
Oh yeah, and if you can, please fill out the survey. We will follow up with you, phone call, text, spam message. No, I'm joking. If you don't do that, we would really appreciate it if you could. Just to be aware too, these kind of symposiums are happening all over the country. So if you go to the KCA website or Judy Nicholson, there's always events around. Meaning that if you have friends, family that are not here in the area and couldn't make it today, there may be something upcoming where it's closer to them. I've heard talks of Chicago, Vegas, all over the place. So keep that up to date, keep other people. I think, again, you guys have now had this experience. If you can share that with other patients who are not as knowledgeable about that kind of thing, I think it goes a long way to helping those patients too. All right, with that, I just want to thank everyone, and everyone travel home safe.